We're going to go ahead and get started with our next hearing. The Chicago Department of Public Health, we have with us here at the dais, Commissioner Hrg. Commissioner, would you like to introduce the folks that you have with you?
Yes, thank you, Vice Chair Lee. I have here with me our first deputy,
Fakurdi Wagao.
and our Chief Financial Officer, Mary Emmanuel. And we have in the box our deputy commissioners and some of our program leads.
You can go ahead and read your statement if you'd like.
Thank you, Vice Chair, and good afternoon, everybody and members of the City Council. I am Dr. Olusimbo Hrg, and I'm the Commissioner for the Chicago Department of Public Health. And I want to start today with the 3 Ps of public health. Public health is about prevention, it's about protection, and it is about promotion. And as a local...
Dr. Hrg, hold on one second. Can I ask that in the gallery, can you guys take the conversation outside? People are having a hard time hearing. We good? Okay, go ahead.
Thank you. So we are mandated to prevent diseases, to protect the environment and ensure food safety, to promote health and link it to care. And because prevention is often invisible, today I want to start by shedding some light on how we detect and mitigate threats to the health of Chicagoans. So let me start with preventing disease. CDPH was trusted to keep thousands of delegates safe during the Democratic National Convention. We always like to present the counterfactual because when we prevent things, they're sometimes invisible. So hundreds of thousands of delegates in our city, and we had to prepare the healthcare system to handle scenarios ranging from bioterrorism, and that included 16 trailers of antitoxin that we had to store and warehouse and prepare a continuity of government plan. We also had to take samples of wastewater from all of the different locations where delegates were housed twice a day to ensure that we were tracking every possible disease that could emerge. We were tracking diseases from every country around the world that could potentially come to Chicago. And we also ensured that food was safe. More than 40 different restaurants were involved in this event, and we were doing continuous monitoring every 2 hours to ensure that the delegates were safe. We prevented any outbreak. You did not hear of any disease outbreak because we prevented it. This year also, we had a measles outbreak, the largest of its kind in 30 years and the largest in the country. And we were able to limit that outbreak, even though more than 2,000 people were exposed to measles, to just 57 cases. It could have been hundreds. And we worked tirelessly, hundreds of people working together to ensure that the disease did not spread. This prevented school closures, it prevented the economy from being unencumbered, it prevented the city from being shut down. The city remained safe because of the work we do in prevention. This response earned national recognition for promptness and effectiveness. Every day, there are 70 mandatory diseases that we must monitor, and we monitor them. This year, we have responded to 261 outbreak notifications. And we set ourselves a goal this year. If we get an outbreak notification, we will be on the ground in 24 hours. And I'm proud to tell you that 100% of these cases, we were on the ground in 24 hours. This is how we keep our city safe. We have responded to outbreaks in healthcare systems, including microbial resistant outbreaks. We have responded to outbreaks in long-term care facilities, in correctional facilities, in schools and in daycare, responding within 24 hours and containing every instance. You did not hear any of this in the news because we prevented it. Now let's talk about protection. How do we protect our communities from health risk? It requires detection and also understanding what the health hazards are that face our community. When parents consent, we go to their homes and ensure that if you're a new parent in the city of Chicago, you are offered a chance for a home visit by a public health nurse. When that person visits your home, they will not just assess the health of the mother or the child, they assess the conditions of the home as well. This year, 2,200 families have benefited from this support. Several hundred sudden infant deaths have been prevented because now families know how to ensure safe sleep practices. Do you know the numbers of sudden infant death is now down to 175 in the entire city? Our goal is to get that to 0. And we're working hard to ensure that all health hazards in the home are remediated, including lead. This year, as at August, in the end of August, we inspected 768 homes for lead. We get a notice, a child has lead in their blood, we're there on the ground, again, as quickly as we can, and we inspect the home. If we find lead, we remediate the lead at no cost to the family. And we have successfully remediated lead in 245 homes just this year alone. We keep homes safe. We keep families healthy. We keep communities thriving. We have ensured that in our city, the 15,000 licensed food establishments are safe. We have ensured that several hundred food vendors at special events adhere to food safety. I was at Lollapalooza. I was at NASCAR. I was at Taste of Chicago. We do 2-hour monitoring, checking food temperatures, making sure food is handled safe. And that is why there were no food outbreaks. And this is what makes us proud, ensuring that our city can continue to be the tourist hub that it is. We have prevented hundreds of foodborne outbreaks, and we have contributed to the economic vitality of our city. One of the reasons people come to Chicago for tourism is because of our food. As a result, businesses have continued to serve Chicagoans, and our city continues to thrive. Safe food tourism contributes to the reason why Chicago has been voted the best big city for 8 years in a row, because we keep the food safe. Every day, we also ensure that the air is safe and that our homes are safe. We have already received more than 7,500 service requests through 311 this year. People ping us, we respond. Mostly, the concerns that we get in CDPH are related to food and environmental concerns. And do you know, as at this morning, when I checked our 311 dashboard, our number was already at 88%. When I wrote this, it was 87%. We respond to 88% of the requests we get through 311 within 7 days. Our city is safer because we have a robust public health department. Now, my final point is about promoting health. Our summer opioid response this year led to a 23% reduction in overdoses and almost 50% reduction in premature mortality. People dying from opioid reduced from more than 1,000 to about 500 this summer. We came before you earlier this year to present a plan for how we want to address opioid overdose, and we delivered on that plan. And now we have all kinds of press releases and national recognition because we have reduced overdose incidents in Chicago by almost 23%. We want to say a big thank you to the 40 community organizations, the mayor's office, Chairwoman Rodriguez Sanchez, members of the Committee on Health and Human Relations, and the West Side Alders who partnered with us. We canvassed 1,300 blocks. We went from door to door. I was out there door knocking with my colleagues, and these are the success stories we have. All public schools in Chicago have benefited from oral and vision and sexual health services. Do you know more than 50,000 students can get their eyes checked while at school, can get their teeth checked while they're at school, can have sexual education at school, and that is because of the work we do in CDPH. And so these kids are better able to focus on their studies. We have a supplemental nutrition program for women, infants, and children that has provided nutritional support to more than 17,000 families. And this does not impact the ability to also have SNAP, complementing and supplementing the nutrition that families need. During the summer, more than 30,000 children participated in play streets. Why is this important? When kids are active, they're mentally sound, they're physically sound, they develop social skills. This is how we promote health. Promoting mental health requires developing social skills, and mental health also requires being able to be physically and emotionally active. And that is what Play Streets provide: physical, mental, and social skills. We have collaborated with many stakeholders, and we are grateful for their commitment to bring mental health expansion to life. The mayor's office has had our back. They have provided support. Chairwoman Rodriguez Sanchez, the health committee, the budget office, human resources, fleet and facilities. It has taken a village, and the public safety department have worked together with us. Hundreds of community partners. We have hired new staff. We have expanded mental health services in 3 locations. We have even expanded our behavioral crisis response team to ensure that we have citywide coverage. These are the accomplishments in just this year alone, 2024. Critically, all of this was accomplished without disrupting provider continuity for folks receiving care through other systems of care. Outside of mental health, the majority of our work is supported by grants. More than 82% of CDPH's budget comes from federal grants. More than 500 million of our work is supported by one-time grants that will end in 2026. And so sustainability has been a top priority for CDPH. We have been planning for this scenario from day one. When you get one-time funding, you have to start with a sustainability plan from day one. And that is what we have done. In anticipation of the end of this grant, we have started to explore creative solutions in partnership with community organization, collaboration across government, and I look forward to continuing to work with this body and our county, state, and federal partners to ensure that public health services continue post-COVID one-time funding. Looking forward, we have also developed action plans to address identified community health needs with a focus on health equity and closing the racial life expectancy gap. Our city continues to be impacted by premature mortality. That's death before the age of 65. The number of deaths before the age of 65 and the gap in life expectancy in Chicago is double that of the national average. This must be a priority for us in public health. And the reasons for this premature death are chronic disease, especially heart disease, homicide, opioid overdose, infectious diseases, and infant mortality. And we remain resolute to address these issues. We also recognize that mental illness contributes to premature mortality, and this is why it continues to be a priority area of action for us. In 2025, we will address the 6 drivers of life expectancy gap, especially in the most impacted communities. There are some communities in our city that not only have lower life expectancy, but that the life expectancy is declining. We must prioritize them. The history and persistence of racial segregation in Chicago has limited access to resources, creating obstacles to health, and we must help to remove these barriers. We will ensure that the South Side and the West Side neighborhoods, where the lowest life expectancy are concentrated, must benefit from all of our programs. We are poised to layer our intervention, not one disease at a time, but all of it at the same time. We will implement a data-driven, asset-based, hyper-local, collective impact approach. And the reason we know this works is because we tried it this summer for opioid overdose and it worked. So we want to replicate this in more neighborhoods. We call this precision public health. We want to go to where the problem is and remove the barriers. And we know that it works. We have experienced it this year. And so our action plan for 2025 will leverage the existing resources and partners in the following way. We want to work with community health workers and community partners to increase access to chronic disease prevention. Remember, we're in the business of prevention, we're in the business of promotion, and we're in the business of protection. And so we must ensure that there's access to more nutritious food, physical activity, and smoking cessation support. We are also going to be disrupting cycles of violence through hospital-based intervention for survivors and highlighting place-based community safety measures like vacant lot greening and tree planting. Tree planting contributes as much to mental health as antidepressants. There is proven scientific evidence for place-based intervention and its impact on violence prevention. We are going to be further reducing the opioid overdoses through hyper-local engagement and promoting the use of safe medication that minimize craving, lessen withdrawal symptoms, and reverse overdoses. And we're also going to be limiting the spread of communicable diseases. Every day, we are detecting and responding to communicable diseases. And now we have a plan for how we can do that even better in communities that are the most impacted, especially with respiratory viruses. And we're going to be doing tailored messaging to communities of color. Promoting infant and maternal health is a priority. We are going to be increasing access to nutrition support through our week enrollment, data modernization, and increased staff support. And finally, we are going to be promoting mental health, not just addressing mental illness, but promoting mental wellness. And we will be training more community leaders to identify danger signs and work with us to connect loved ones to care. I look forward to working with you to make our work more visible and sharing the progress next year. I want to end by thanking my CDPH team. I have a fantastic team in CDPH, nationally recognized, nationally accredited. We're one of the big cities that receives funding directly from the federal government, very similar to the state. And that is a pride and a privilege that we want to keep going forward. We want to thank the mayor's office and we want to thank the city council. We have approached you several times this year to present plans and trainings, and you have participated and worked with us to bring services to your community. And we will need your help as we go into the next year. We want to thank our public health system partners. There are more health systems in Chicago than in many states, and they are always willing to support and respond to our call. And we want to thank our community-based organizations, researchers, advocates, many other collaborators that have kept us on our toes and partnered with us to ensure that public health is really inclusive of the public. We are resolute. We are committed. We must ensure the health of Chicagoans are protected. And we are in this mission to support the health and well-being of all Chicagoans. And we will be looking forward to sharing updates with you in 2025. Thank you, Vice Chair Lee, and thank you everyone for listening.
Thank you, Dr. Ige. We'll raise your hand if you've got questions. I'm going to provide a courtesy here to our chair, Rodriguez Sanchez. If you'd like to open, you can go ahead. And if you'd like to ask questions, please raise your hands.
Thank you, Vice Chair. Thank you, Dr. Ige, for all the work that you have been doing and your team. It is a privilege to be able to work with all of you in the mission of public health and education for our communities and for our colleagues and for our offices and promoting well-being. I'm going to start with a general question, and I'm going to be sending many of my questions through the share because they're very specific and technical, and I don't want to be here for too long because I know that we still have a long way to go. So we're going to have a new context in January that we know very well because we already went through it. I would like to hear from you. Are we ready, and how are we ready to meet the needs of our community with this new administration that is coming in at the federal level in January, and with the dramatic decrease in COVID funding?
Thank you, Chairwoman, for that question. There are two types of funding that we get through the federal government. There is funding that comes through us through routine appropriation to CDC, and then there's funding that is supplemental funding. So supplemental funding is often one-time funding, and many of the funding that is supplemental, we are notified that it is one-time, they're not renewable. So during COVID, we got a lot of supplemental funding, several hundred millions of it. We are not anticipating that that funding will be renewed because it is supplemental. However, we are up for reaccreditation this year, and we are working very hard to ensure that we remain a low-risk partner so that we can continue to benefit from federal grants. And we are working with the Big Cities Health Coalition to make recommendations to the new administration about public health priorities that impact health security and impacts the economy. And so we are optimistic that even with the new administration, those appropriation dollars that we get routinely as recurring grants will continue to be recurring grants, and we will continue to benefit from it.
What is the timeline for accreditation?
The budget decisions are usually made in September, October. This year, there has been continuance. So we are still waiting for what the final approval of the CDC budget will be. But we don't have a timeline for when that is going to happen.
Okay. Can you talk about the decrease in funding that we're seeing in CDPH? I understand we've had a conversation and I was briefed about how the opioid funds were now going to be eliminated from the corporate fund because we do have an opioid fund from settlements. Can you go into more detail about how we are funding the opioid response and apart from the opioid response, what other programs are seeing cuts?
Yes. So this year, our budget went down by about 140 million. That is mostly a function of the reduction in our available grant funding. When we receive grants, we get it, upfront, and as we spend, the money goes down. So we were at the peak of our funding in 2024, where we had, upwards of 966 million total. And as we spend down the money that's available for us going forward is lower. So that 140 million difference that you see is because of the reduction in the available grant funds. Now, the opioid settlement dollar varies. I will not say that it is a reduction really, because it varies over time. So we have the opioid settlement dollars that support our opioid response. The activities that it can support are very specified. So we have to ensure that our legal team, everything is compliant. So we don't anticipate much of a reduction in the opioid settlement funds this year. But the grant funding is where we will continue to see a decline. This is the first year of that decline, and it will continue until 2027 when all of the COVID era funding will have expired.
Thank you for that. Can you talk about the Roseland location for the mental health center and how are we going to see resources used there from this particular budget?
Yes. So the main investment from CDPH into mental health clinics is really the staffing. So this year, we're very grateful that the Office of Management and Budget allowed us to hire the required number of personnel to run these clinics. So the 3 new locations we've added to our inventory of clinics, that is the Pilsen site, the Roseland Clinic, and the Legler Library. We have the staff hired to be able to start operations there. For Roseland, though, there's also need for some repairs work that is under the Department of Fleet and Facility Management. But for the staff that is required to run services there, we have those staff hired.
And do we have a sense of what kind of programming besides what we have talked about, therapeutic services? 'Cause we have seen Roseland as a hub that can have more resources for people and not just the therapeutic services. Do we have a sense of how much of that we're going to be able to accomplish with this budget?
It is work in progress. We have a sexually transmitted infection clinic there. We anticipate that we will also be able to provide vaccination services there, similar to Pilsen. And we also hope that we will be able to have a community health worker partnership, helping to navigate people in addition to the mental health services. We are continuing to explore what additional resources we can bring closer to the community as we go. But, as our funding evolves, we will know what the final scope of services will be. But at a minimum, we believe that those services will be available when the clinic opens in December is what we're hoping.
So for the Roseland location, when it opens in December, we are still going to have the STI testing and we are going to have therapy and then we're going to build on that after? Is that
Yes.
what you're saying?
That's correct.
Okay. Can you talk about our ideas or plans for the integration of the mental health crisis response, the care component with the mental health center work?
Yes. So our outreach team, we've looked at the data and looked at the profile of those they are engaging and what kind of services are necessary. What we have noticed is that about majority of those they are engaging need social services. They need housing, they need food, they need clothing. Some of those issues can be resolved by connecting them to other services. Mental health services, there are a few instances when people have severe mental illness and need to be stabilized. So we are working with existing stabilization units that are closest to where people are found to connect them to services. And the reason why that's important is that severe mental illness requires ongoing support. It's not a one-time thing. So we want folks to have community assets that can continue to provide that wraparound support for them after we have resolved in the moment. So we leverage our community partners that have living room services there. What is required to integrate living room services in our facilities right now is quite significant, especially in terms of space and the staffing, because it requires 24-hour coverage. So it will require significant staffing, significant space to be able to replicate, you know, a living room model that will be certified by the state. So in the interim, though, we are working with partners. We've already identified the partner, and the state is funding 4 new CCBHC, and we've already started negotiation and partnership with them.
I'm looking forward to working with you to accomplish that from the city because I think that's a really big dream for us to be able to use our mental health centers in that way. I'm going to ask one more question. I'm going to send some through the chair. You talked about the need for awareness about the mental health services that we are providing. Can you talk a little bit about what CDPH is going to be doing about that?
Yes. We found from the annual community health surveys that we do that there are people who have moderate to severe psychological distress that are not connected to services. And the question is always why? Is it because they're not aware of those services? Is it because they don't want to come to those services? Is it because there are other barriers? So we continue to explore the reasons why people are not connected to services. But for our services, we've done some community engagement and focus groups. And we have found that the physical condition of our services can be unwelcoming. Our services are not always updated. They don't always look as pretty as all the other locations. Engagement with staff and providing clarity of information. So we have taken this finding and worked it into the design of our clinics now, ensuring that our spaces are welcoming, that they incorporate, you know, design and arts in our spaces, that our spaces offer people options beyond just therapy. They can have medication management, they can have yoga, they can have, you know, sensory, you know, therapy, etc., so that people have options when they come to our spaces. And we are also even going as far as having open houses so people can come and see the space, and so that by word of mouth we can share that word. We are also doing canvassing, door knocking, and going around from door to door, letting people know where we're here in our community. We're worked with we have a list of all community partners, so they know that we are bringing services to the community. So we are working hard to ensure that people know that we're there and we've listened to them, and we have created welcoming spaces for people to come. And if we're not able to provide what people want, we also have now an inventory of partners where we can actually do warm handoff, not just a call, but we can actually track in the system if they have been connected to those services, so that we are a one-stop health center for our communities.
Love the idea of the city knocking on your door to actually offer a service. I already know several people that have made appointments at the Pilsen Clinic. and they're very happy. So thank you so much for your work, and you will get the rest of my questions through the chair.
Thank you. Thank you, Chairman. Alderman Dow.
Thank you, Chairman. Hello, Dr. Ige. We have not met, but I see that you share a characteristic of Dr. Arwadi, which is long answers. So I would ask you to um, try to keep them short for me because I only have 10 minutes. The environmental, first of all, I want to just say, even though we have not met, I want to just acknowledge Alfonso, who keeps me abreast of what is going on in your department since we have not really connected. So I just wanted to say that. But can you talk to me about your environmental permitting and inspections division? There's 34 individuals there. I really want to know what their responsibilities are. What do you see as the vision for that? And then I have a follow-up.
Thank you, Alderwoman. So our Office of Environmental Permits and Inspection has 4 main responsibilities. We do permits for new operations, new industries, and that includes reviewing the air emission potential of those new facilities. We do inspections. So when we get requests through 311 and people have concerns about any operation, we check that. We oversee demolitions and anything that has the potential to emit dust or other particulate matter that is of significance. And those demolitions, we can categorize them as environmentally complex or not. And if they are environmentally complex, we also organize the community engagement to let people know what to expect. And finally, we also collect data and do monitoring on the air quality, remediate chemical, radiation, and other environmental hazards.
Okay, the reason I asked that is because over the last year and a half, I've been approached by, at least 3 different data centers. And there seems to be a growth of that in our city. And I'm wondering the extent to which your department can address that. We want that to happen in our city because it means more tax dollars for the city, but the proliferation of them, the cumulative impact of them, what is your department doing?
For our work right now is guided by the Air Quality Ordinance of March 2021, and that limits our authority to consequential facilities, certain types of industry. Data centers are not included in that list at the moment. We are open to supporting the review of any potential environmental hazard that could result. Our main concerns are related to the use of generator and noise from those centers. And right now they have some plans about how they will solve for that. But we will be interested in just seeing in real time as this data centers are established, what the environmental impact is. But right now, we do not currently have authority under the ordinance to oversee or regulate data centers.
So how would you suggest I deal with the impact, the possible impact in terms of particulates and, who is going to help me make those kind of decisions on whether to support something or not?
We typically start with the US EPA standards and regulations, and if there are some guidance there, data centers are relatively new right now, so it's really in the exploratory state for now. And we're hoping that over the next year or so, if there are opportunities to actually collect data and see what the impact is, how much emissions are they generating, and how much that's really through the use of their generators, how much those generators are emissions are coming from there. And then if there are any other potential hazard, I think the generator component is what we are most interested in.
All right, so maybe after this, I will like to sit down with you, and I know Renate is gone, and I believe David is taking his responsibilities, but I would like to sit down with you and see, how to address this pending good problem, perhaps, in my ward. Uh, I wanted to get through the chair a list of all of your programs by funding source and indicate which do not have funding past 2025, if I can get that through the chair. This morning, we had someone from the public who, Creole Hampton, who said that you were going to give Black-led HIV organizations $3 million a year, and I just wanted to know if that was accurate.
The number, our HIV funding, there different grant funding. I believe that the reference will be to the Ryan White funding. It is a federal funding. That funding, 75% of it must go to medical services treatment, and then 25% to community treatment. This year, because of our goal to get into zero by 2030, we have started to look at which groups of people are not moving along as fast as we want to. And that is the Black gay men and Black transgender men, Black and Latino transgender men. So we have requested to focus some funding on engaging those communities that are likely to be the most
That is
impacted.
non-Ryan White funding, you're saying?
That is Ryan White funding.
You don't have any other source of funding for that particular health problem?
We do. We have HOPWA, which provides housing. We have CDC prevention grants that also provides HIV funding. I think we have about 5 or 6 different HIV funding. They
Can I
all
get that through the
designate.
chair?
Will
What,
do.
so I can get an understanding of what that funding stream looks like? All right. I noticed in the budget that you spend almost $1 million on your own human resources division. And my question is, why does CDPH have their own human resources division when we have a department that does that?
It was a response to the many grants that we got during COVID. We manage about 80 grants. And because of the short-term nature of the grant, it becomes necessary to hire people really quickly. And our Department of Human Resources supports 40 departments. So during COVID, the Department of Health had particular need to staff up really quickly, and all of those funding will be going. So that size will be shrinking as a result. But that was a response to the COVID era funding where we needed to hire. We've
So
hired.
do we need it for, we're trying to find ways to make a dent in our budget. $1 million is $1 million.
Yeah.
Is this something that your department could do without?
It is grant funded positions mostly. So when the grants end, those positions will end.
I believe I saw that in the corporate budget.
Correct? Yes, please.
Am I wrong? Is it not in the corporate budget?
It is,
Plus,
Please state your name for
yes,
the record.
Fakurdi Wagau, First Deputy Commissioner. Alderwoman, we've had an HIV division before COVID. Dr. Ige was referring to the growth in our HIV unit to support the
Not
growth.
HIV, HR.
I'm sorry, human resources to support the growth in our staffing. We can talk to HR, but our human resources provides a lot of hands-on support for our employees, processing leaves, payroll, et cetera. And I think to Dr. Ige's point, as our one-time COVID funds shrink, we expect that a lot of our shared services will also shrink.
Okay, I'm putting that in the parking lot because that's might be some money we could claw back. Your settlement funds, what's your long-term plan for when those funds run out?
We have the settlement fund for about 10 years, I believe. And a lot of our work is grant funded. So we always plan for the duration of the grant. And when the grants end, if we don't have a recurring grant or another grant, then the work will transition either to county partners, state partners, or community partners that are in similar areas of work.
Okay, and do you know how many settlement funds you're working with right now? I know that there's
Vaping and opioid.
epidemic, or I know you have some for epidemics. What, do you know how many of those settlement funds you're working with right now?
We have two settlement funds, the vaping settlement fund and opioid settlement fund.
Thank you, Miss Chairman.
Thank you. Thank you, Alderwoman. Alderwoman Haddon, followed by Alderman Moore. Okay. And anybody else? Okay.
All right, thank you, Chair. Good afternoon, Dr. Ige. All right, I'm going to try and run through these questions pretty quickly too, because I got a few. So I just want to start off. So thank you for your comments and prepared remarks today. It's good to hear about all the kind of progress that you guys are making, especially on these core health services. I know that the Department of Public Health has always been important, but certainly these last few years have elevated departments of public health around the country just into spotlight all the time. So we appreciate you guys and the entire team. Certainly, we've gotten to know you better than we might have otherwise. I've got a few questions more on the environmental piece. So, wondering if you could speak to the air quality monitoring program. I know there's supposed to be a thing tomorrow with, kind of the deployment plans. And is that happening tomorrow? And could you speak to the air quality monitoring program?
Yes, the meeting tomorrow has been postponed until after a budget hearing when we can reset. The air monitors have been procured. They have been calibrated. So our advisory governance team is the advisory body is working with us to identify the locations for the installation of the monitors. So that is the next step, and we will be scheduling that meeting.
So I would love if you could, please loop in my committee team on the rescheduling of that meeting so we can just kind of make sure to be on it and participate. And we want to make sure that happens and to continue to work with our community partners to let us know that there is still that commitment for that program. I'll say a similar question just around the tree advisory committee and wondering if there are any updates on that and, if we're going to continue to see work on this in 2025.
Same plan. We are postponing the next meeting until after our budget hearing, and a new date will be sent. We sent a notice to our community partners to just give us some time to find a new date for the tree equity meeting. So the air monitoring, tree equity, all existing work will continue. We're just fine tuning dates and when we'll be able to regroup.
So similar request on that one, particularly in chairing my committee. We also serve on the Urban Forestry Advisory Board, so would just love to just keep me in the loop, let me know when that's happening so we can also work and with our community partners on that. And then same question around the heat preparedness initiatives. Same answer?
Yes.
Okay, all right. So we'll continue to follow up on that. And, these are all very important parts of the work, and especially on the heat preparedness. What does 2025 look like in your department position commitments for the cumulative impact work?
So the cumulative impact was started with the data collection and recommendations for both action and policy. Some of those actions we've already started implementing, environmentally complex community meetings, asking for additional data when our industries are submitting for permits. There are some policy recommendations that are outside of the Department of Health that requires the Mayor's Office, Department of Environment, Department of Law to move forward. And so we are waiting on that for when that will be finalized.
Okay, so, and just to clarify, so currently for that work, you're waiting on direction from the Office of the Mayor and the Department of Environment on next steps?
That's correct.
Okay. All right, thank you for that. I know Chair Dow mentioned this, but on the HIV and AIDS funding, I know I did reach out to you. You gave me some good information that was pretty robust on the Ryan White Part A funds. This is just a clarifying question. So for the portion, I think it was around 2 million that the advocacy groups of Black-led organizations working in this space for HIV and AIDS care. They said that the 2 million was set aside for organizations who have EDs that are Black gay men. I'm wondering, is that specifically true?
Organization that serve Black gay men.
Okay, that serve Black gay men, but it doesn't have to be led by a Black gay man.
Where we are not able to restrict that way. We're able to say these are the most impacted. So if you serve that community, then you're eligible.
Okay, and are there any similar focus points permitted within that grant structure for Black women who are suffering from HIV or AIDS?
I will look into that and get back to you with specific. The increases we've seen is mostly in the Black gay men community and also the transgender community. So there are two components to this: preventing new infections, uptake of PrEP and all of that, and also ensuring that people are staying connected to treatment. So we will look at our data and see where we will have justification to designate in that way.
And then another, so sorry, they're all rapid fire questions and we're just going to go all over the place. Chair Dow asked for kind of a list through the chair, right, of programs that might be expiring through 2025 for CARES funds. I'm going to ask, in addition to that, if you could, through the chair, provide positions that would be are going to be eliminated at the end of 2025 or sooner as well, that are tied to CARES or ARPA dollars. That would be helpful. So the titles and kind of numbers of the positions, what that budgetary impact is going to look like, if we could get that through the chair. And I know, just like off the top of looking through some of these budget impacts, I see funding for community health workers, for behavioral outreach, community mental health, expanded street outreach, the Link Up and Link Match program. Like a lot of those are funded through CARES. So I'm assuming, looking at even just that pot of funds, it's like $12 million there that we won't have after 2025. And I'm assuming those programs will go away. But I guess my question is, are you currently in planning with the budget office or the mayor's office to be able to give us, through the chair, a list of programs that you plan to continue or seek other grant or corporate funds to continue after the CARES and ARPA funds expire?
Thank you, Chairwoman. Our corporate budget right now is 76 million. Our one-time COVID funding was over 800 million. So we anticipated that it will be a big drop-off. So we've mostly focused on programs that we either had before, expanded, and then will contract. The new initiatives we started were designed to be like proof of concept that we could shop around after. We have been in close conversation with the city about which of these can transition. So we have about 347 positions that are on one-time COVID funding. All of these positions where we were clear during hiring that they were one-time positions because they're grant funded. We have been able to identify recurrent grants for about 40 of those positions. But as at today, 15 of those positions we haven't identified alternative funding for. So our plan going forward is really how do we connect with county and state to see, and maybe philanthropy to see which of those programs we can transition or get additional funding for.
Is it I'm gonna go do with the chairman on y'all. Excuse me, hold the time.
Oh, it's,
Okay.
she can use the last 48
Okay,
seconds. I'm
all
good.
right.
Thank you, Dr. Ige. Yeah.
Alderman Dow.
Thank you, Madam Chair. I just want to ask Alderman, what's your name? Maria,
Alderman Haddon.
Alderman Haddon, thank you. I had a senior moment. If we can get that information that you just asked for and the information that I asked for together, so it's not separate. Thank you.
All right, thank you. Alderman Haddon, Alderwoman Haddon, you're good?
All good. Thank you. Thanks,
Okay,
Dr.
Thank
Ige.
you. Alderman Moore, Alderman Lopez, you're next. Come back to you later. Oh, great, okay.
Thank,
All right. Look, you're a non-member, so I gotta wait to the end.
thank
Till these other members get here.
you so much, Chairman. I appreciate it.
You tried, though, Alderman Moore.
Thank you so much. A couple of my questions have been asked and answered. First of all, I want to thank you and your team for your service. I know we don't act a lot, but I do see you periodically. And I just want to thank you for, well, at least thank the work that Alfonso is doing because he keeps us in a loop and always being proactive to anything that we need. I just want to echo so you know it's important. And I know things have been asked for through the chair, but so you making sure that organizations that's on the ground that's interacting with HIV patients and especially in African American communities are making sure that they are getting those resources, so to speak, like we're doing with violence prevention, where they're trying to get it down to the level of those organizations. So I want you to know that that's a critical piece and things that we're hearing in our community. And so I just want to make sure I echo that as well. The other part has to do with, and this may also go towards to DFSS in terms of senior service, but I want to know how you all are working together in terms of outreach and your dollars for outreach. We got our seniors are living longer. We're doing events where, resolutions, somebody turning 104, somebody turning 105, and our seniors are living longer, some healthier, some not. Are you doing outreach programs to inform seniors and families of how we deal with, long-term healthcare issues, or is that a DFS thing, or are you doing outreach? And if so, where is it in your budget that you have the funding for that outreach?
Our funding is typically tied to particular issues rather than particular populations. So the issues that particularly impact seniors during COVID, respiratory viruses, yes, we do outreach in collaboration with DFSS, organize vaccination events with them, mental health issues, also ensuring that we are reaching that population. We just had, an AARP meeting that I was on with the director at the state with almost 800 seniors on the call. So we do reach out for specific health-related issues that impact seniors, and that's in collaboration with DFSS.
And what are some of the main issues that you are seeing with our seniors? What are some of the top three? And I'm not talking about just doing around COVID, but just as they're living longer, what are you seeing?
Infectious diseases particularly impacts those who are 65 and older. And we see a lot of that. Most of the disease outbreaks we see, nursing homes, long-term care facility, mostly seniors. Then chronic diseases, heart diseases, diabetes. Again, seniors are the most impacted there. We do not right now we have very little for chronic diseases. So we don't do a lot there, but it is an area where we're collaborating with community health centers and healthcare systems to just better reach and engage our community. And then mental health. The isolation from COVID is a challenge. And what we do there is our partnership with the Community Health Response Corps. We have a hotline where people can call and get information, and we also do outreach that's on the ground canvassing, getting to faith-based organizations, other organizations that serve seniors to just get information to them.
So, and now let's get into the infectious diseases. Is there one that's stands out more than another that you're seeing amongst our seniors?
Right now, respiratory viruses are the main problems. Pneumonia from all kinds of causes is always a thing every year. Flu, hospitalization from COVID, RSV, all of those really disproportionately impact seniors.
So, then to my question where I started out at, how are we reaching our seniors to talk about this? Is it left upon DFSS, or is it coming out of your department? Is it a shared responsibility? How are we reaching out to our seniors for to inform and educate instead of them? Because most of them just run into the doctor, right?
Right.
What are we doing from the city standpoint to say, hey, this is how, we can, or things we can do or services that we can provide?
It comes from CDPH. We collaborate with DFSS for locations to go to their senior centers to get a list of the senior centers so we can go there and get information to them. And the 3 ways we get information to seniors, most seniors have a primary care provider. You cannot be 65 and not have a healthcare provider. So we use our Health Alert Network to get providers to proactively reach out to their patients and say, this is necessary, you're due for XYZ. That's one pathway. Then engaging senior centers, that is collaboration with DFSS, and then faith-based outreach. So we have partners and we do engagement with houses of worship and go there to provide information, which is also another way that we get to seniors. And then our community health workers that just canvass neighborhoods and engage people as they see them.
And so from your budget for that outreach, because I visit a lot of churches, and not that you're going to be there at the Sundays I'm on there, or that I'm there. When I think about when I was at the Board of Review, every time it was around for tax appeal, we would do community outreaches for tax appeals at churches, and we would hit these churches, and you knew it was coming constantly throughout many churches. And so I'm not hearing about this, and I'm connected to the church base. So how is this? What is the budget, and how many churches are you hitting? If you don't know that number, you can provide it through the chair, but just give me some, because I'm not seeing that. I see, other, organizations with health organizations, companies trying to get people to sign on, and they're showing up and they're doing that. But I don't see the city of Chicago out there at those churches. And I'm not saying out there, I probably missed it, but.
You may be seeing our delegate agencies. We'll get you the information. It may not be City of Chicago staff, but our delegate agencies, our community partners should be engaging, and we'll get you that information. We have events in all 50 wards. We have a long list of scheduled and outreach events in every ward. So we collaborate with our delegate agencies. So they may be the ones you're seeing. We have Gold Star, that is the faith-based partner. We had the Day of Prayer last week across many different houses of worship. But we'll get you the detailed list of the outreach.
Yeah, so just provide through the chair, the where the delegate agencies and they should have a list of where they went, right? and provide, where they went last year, so I can get a good feel of, how these seniors are, this information is getting to the seniors. So,
Will do.
thank you, Chairman. I appreciate it.
Thank you. That's answer your questions, Alderman. Okay, thank you. Alderman Sposato, followed by Alderman La Spada.
Thank you, Madam Chair. Thank you, Dr. Commissioner. How you doing? We've also never met, but that's really a good thing. So if we don't have to meet with you, so you have a guy, your IGA guy, so he certainly keeps us informed. So I just want to let you know that. So if ever I have to knock on your door or call you, I'm sure there's a problem. So, but with him here, it sure does help us a lot. And I know I'm repetitive from what the rest of my colleagues are saying, but we really appreciate them. I don't have any questions. I just want to say thanks for doing what you're doing. I'm a little bit of a bearer of bad news. There's some, our former commissioner doctor was terrorized by a woman who just happens to be on the school board right now. So I hope this same lady doesn't do this to you, come out and protest at your house and wreak havoc upon you if you're doing something that she doesn't agree with. So with that, I just want to say best wishes to you. Keep up the good work, and we're behind you, and just keep that guy around to keep us informed.
Thank you. Alderman.
Appreciate you.
Thank you.
Thank you, Madam Chair. Oh, Madam Chair, I'm not sure if I ever got credit for being here for part of the quorum, so if you can leave a note to the chairman, I greatly appreciate it. So,
I will leave a note for the chairman.
all right, thank you.
Thank you. Alderman La Spada.
Thank you very much, Chair. Dr. Ige, thank you so much for being with us today. Across the board, the work that your department is doing is so integral to the health of our communities, and I've benefited directly. I really appreciate particularly the work that your department did on our recent COVID and flu vaccine clinic in the ward. So thank you for that. Truly, like in the interest in seeing you all be successful, the persistent vacancy rates are really concerning, and we're lower than we were a year ago. I think a year ago we were at 493 vacancies that we're carrying over. This year we're at 280, and about 41 of those look like the same titles that we saw vacant last year. And as much as we're talking about departmental HR, citywide HR, what do we need to be doing to help you all staff up on these positions? I think particularly around some of the mental health clinician posts that have been vacant for a long time.
Thank you, Alder. We have worked really hard this year to address those issues, and there are a few things that we found. We actually did an assessment of the rejection rate when we make an offer to candidates and they say, no, thank you. We had 103 rejections this year when people say they have better offers from other places. So that's one factor. The second factor is there are some positions that are just very hard to fill, especially our clinical positions. For 3 years, we've been trying to hire psychiatrists and psychologists and clinical therapists 3, and public health nurses, supervisors, sanitarians, environmental engineers. For example, as psychologists, we offer about 90,000. Those psychologists can make 300,000, 400,000 in private practice. So we're not very competitive with clinical positions. So that is also something that we wrestle with. And then finally is there is just a nationwide shortage. We are part of the Big Cities Health Coalition. This trend is in pretty much every health department. Just this challenge with getting people into public health. And so we are exploring creative solutions for how can we pivot our work, how can we be more attractive. We have looked at retention rates also, where can we do better to retain people so we're not constantly having vacancies. But those are by far the 3 major factors that we noticed.
I appreciate that. I want to dig in for a moment where you talked about psychologists, psychiatrists, the clinician 3 program, because when we talk about mental health, when we talk about the care program, it doesn't work at all if we're not able to hire for those positions. What is the solution there? Like if the solution really is that we need to offer more competitive salaries, I think council needs to hear that, because there's no point listing a position if it's just for show. Like if there's not a world where we're going to be able to fill it at the salary that we're offering.
We did an actual report with Cook County on the mapping of just the behavioral workforce and what will be necessary to fill the gap. It was a collaborative effort with Cook County Health because they're having the same problems. So there's been a lot of work done to just identify what the staffing needs are to meet the needs in our city for just behavioral health workforce. So there's been some thinking into, but we do know that the needs and the supply of workforce just far outstrips our ability to generate the pipeline to meet the needs. So we've begun to explore creative ways to better leverage the resources that we have. So when we talk about our Family Connects program, for instance, where we have public health nurses, can those public health nurses be trained to identify postpartum depression and connect people to services? That way, we don't need another step of a clinical therapist. Can we look at other ways that people can get mental health support? So the healing arts, for instance, we now have a collaboration with DCASE. This is now a nationally recognized program where non-therapy, non-medical options are being offered to people that have been proven to be effective. And now we have about 50 community health workers that are certified providing those services. So those are some of the strategies we're exploring to continue to meet the needs while we'll figure out how to close this workforce gap.
And I know I'm eating up my time, but it matters to me. So one final lens on this, the Roseland and Pilsen clinics that we're talking about, are they fully staffed? And if so, how are we successful in staffing up those clinics?
It has taken us, DHR, we have bi-weekly meetings. We have reached out to every platform, every place where we can to get those staff on board. We have also had to make some changes. We have had to recruit clinical therapist 2 instead of clinical therapist 1. We have had to recruit psychiatric nurses instead of psychiatric doctors or psychologists. So there are some ways that we have just explored solutions to staff these clinics. And we continue to, again, collaborate with others. Sometimes it's part-time staff that we can have because they are working in 3 or 4 other locations. But those are some of the strategies we've used. But it was a lot of intensive effort, outreach. I'm posting on LinkedIn, I'm posting on Facebook. Everybody's posting in all their networks. I'm trying to get the staff.
Okay. In the meantime, we'd see a reduction in the funding for the care pilot of, I guess I would guess around 11%. What is the impact on that of the level of service that we're able to offer through the care program?
The care program right now is mostly upper funded. So it is one of the programs that's on this short one-time COVID funding. So we are continuing to be in conversation with the mayor's office about how to sustain this program. In the interim, however, we are working with the state. The state also is funding behavioral crisis response team to collaborate with them. We're working with the county. There is now a behavioral crisis hub for the city organized by UIC that we're collaborating to make sure, again, that there are no gaps and we are complementing rather than supplementing. The good news is that there is now more investment and resources in this space than ever before. So it's not just on us as the city to meet the needs, but we will continue to strategize about sustainability of the program going forward.
Do I remember accurately that there is either a Medicare, I believe like a Medicaid reimbursement rate for certain forms of behavioral health intervention?
That is correct. That is something that is in the works at the moment, the 1115 waiver. We do not yet have a timeline for when that will be active, but the state is moving that forward and we're very excited about the potential for reimbursement for some services.
Okay. With my last 2 minutes, can you give us, let's say, a conservative timeline for when council will understand the deployment plan for the air quality monitors that we've purchased and are now working on? No, the purchase is done, calibration is done. When should we see like a tentative plan for the deployment strategy?
Our goal, the timeline for this to be launched was January 2025. So what is pending right now is just agreeing on the locations. So we don't expect that that timeline is going to change.
We don't so I feel like you just said that the timeline is still for January 2025, but we don't know where the locations are going to be.
Yes, because we're waiting on advisory, the governance, the air monitor governance body to finalize where the locations will be.
And the next meeting of that board has been postponed, correct? Do you think we're going to hit the January 2025 launch date?
I am hopeful that we will. We are not pausing or stopping the work.
Okay. My last question that I'll get in is, I did not know until we were in this committee meeting that we had a tree advisory committee, because I thought surely she's talking about the Urban Forestry Advisory Board, but they're two different things. One that seems led by Department of the Environment, the other by yourself, Streets and Sanitation doing parkway trees, CDOT doing like arterial streets. What is the locus of collaboration where our urban forest sits? Can you explain how these different organizations and groups interface with each other?
I will talk about the tree equity. I'm not as familiar with the urban forestry. I know our staff members sat on that, but I don't think it was something that was led by CDPH. The tree equity work, our staff convened that meeting, again, mostly providing technical support and convening. The work, the tree equity work and the funding for that, it's a collaborative effort among many different departments, but we convened the tree equity meeting. I can get you additional information on the urban forestry, but the tree equity is where I'm most familiar.
Urban forestry, I'm aware of. If you can provide through the chair more details on the particular roles of the tree advisory committee, I'd appreciate it.
Will do.
Thank you. Thank you, Chair.
Thank you, Alderman. Alderman Cicho Lopez, followed by Alderman Robinson.
Thank you. Thank you, Chairwoman, and I thank you, Commissioner, also for your efforts on the measles vaccination and to work to reopen a desperately needed mental health clinic in our community. I appreciate all of that. My concerns in terms of the budget, right, is a significant budget cut for a department that is critical for the city. We're seeing the life expectancy among especially Black and Brown Chicagoans decline significantly. And I think public health is critical for us. So it seems like a lot of the cuts, seems like it's 77% for what the report of office management has is in contractual contracts that the city has with the public health. So I have some questions around that. And we have had issues with procurement. One of the issues also that is very important for us is environmental justice, as you know, and are you sharing the responsibility with the new Department of the Environment. But does CDPH monitor the environmental requirements of the city contracts? I know that there's been issues in the past, but I think that some of it cuts in terms of like inspections and that stuff that will have significant effects in the oversight of these facilities, the polluters in particular.
Thank you, Alderman. I'll start with the changes in the budget. Like all departments, we were asked for a 3% reduction, and the non-personnel cost, especially in the professional contractual services, is where we recommended a reduction. So that's what you see there. Those were areas where we feel like there might be other sources to cover the services or collaborations to cover the services to ensure there are no gaps. With regards to the procurement and our engagement there, Our work is guided by the Air Quality Ordinance of 2021. Procurement services is not within that scope at the moment. So we do not have an authority to oversee environmental issues related to procurement by the city of Chicago. We have oversight for large recycling facilities and other consequential uses, but not for procurement services.
Thank you. So then my follow-up question. So CDPH and then in some instances, the new Department of the Environment will be tasked with of enforcing the city environmental ordinances. Is that correct?
That is correct.
Okay. Since because it's a new department, I understand that there will be shared responsibilities. I just want to make sure that things don't fall through the cracks. So let's say if city contractor is cited for breaking an environmental law, does CDPH communicate these to procurement, or will be the Department of the Environment? How will that be communicated to the city per se, so that there can be enforcement?
So if there is an ordinance that has been violated, if we get a request from 311 to go inspect, something, and we go and inspect and see a violation, we will issue a citation to that organization and ask them to fix the problem. If they do not fix the problem, then it escalates, and we will notify that organization they are not going to be able to continue until they fix the issue or they're issued a fine. So those are the measures we have for enforcement, fines and citations. If there is no compliance, then other measures can be taken. We inform the organization itself of those issues. If an organization has a violation with any other regulatory body, there's some things we don't regulate that US IEPA regulates or US EPA regulates. They are obligated to share those violations with us, or we can actually reach out to those organizations and ask if they have violations. So we're aware. We do not currently have a process of informing the city if one of their vendors has a violation. We inform that organization directly when they have a violation, and they have to comply. Otherwise, we can resort to legal means and other measures.
Thank you. And I will, what I mean, what is important, because last year there was a report of that city awarded asphalt contracts worth several $100 million. And I think that there will have to be some kind of mechanism for, the post-award documentation to make sure that there is control and oversight. So, will be possible to get commitments to have this documentation being submitted, or have a protocol. Is that possible to have? Because my concern again is, like, for instance, air monitor. Let me just give an example of that. In terms of air monitoring, right? I mean, I think that here we have at least 3 positions that would be maybe lost around environmental inspections, right? So my concern is what around, and that's what I asked, and I know that we already asked for have a meeting about air monitoring. That's something that is part of a community impact study. So that's what I'm asking, because we do have in the Southwest side a serious issue with environmental pollution. This air monitoring is critical for us. So that's why, it's very important that we continue with that. I know that I already requested a meeting with you to discuss that. So I'll just wait for that meeting to happen so that we can discuss the more particulars, because I want to be mindful of the time, but I do like to request through the chair that information. The other one is around the tree advisory committee. The issue with heat and extreme heat in our city is serious and across the board. It is only going to worsen, I think, with the new administration at the federal level. So I think that with the efforts that you have with the tree advisory committee, is this included in the CDPH plan, the tree advisory committee and their plan? Is that part of the efforts? Will this continue?
Yes, tree equity work is part of our work in CDPH and will continue. Heat preparedness and response is an interdepartmental activity. the Office of Emergency Management and Response is the lead for response to emergencies. So it falls within that. There are several departments that have roles. CDPH has a role in ensuring that we're monitoring data and that we are providing content for to help people, vulnerable populations, protect themselves from heat. DFSS also has a role. OEMC has a role. Other departments have a role. So that's coordinated from the mayor's office right now. But we do have a City of Chicago emergency operations plan that details the different responsibilities of every department in an emergency, including the heat response.
Thank you. Yeah, and just following up with the heat preparedness initiatives, and I want to commend your team, and I know that you've been working with DFSS, I believe, for this response, and I think the importance of collaborating, and continue to expand with community partners. I know that we've been working closely. So my last point, I know that we don't have a lot of time, is around the coordination between CDPH and the new Department of the Environment around enforcement. I know that we do have, as you know, pending permits. We do have inspections that need to continue, yet a much smaller budget. And that is affecting especially this area and the budget that I can see. So a commitment to work and maybe have reports, regular reports on this heat preparedness, air monitoring, that is very important for us. And the coordination between the departments, I do think that is going to be critical. Given the number of need, I just look at the budget in particular. I've received, several letters from advocates and medical research advocates around, there has to be an increase for mental health in terms of like air monitoring and other needs. I do think that the budget, I know there's, in contractual relations, we have about almost $140 million in cuts. I do think that we need to ask that we collaborate to find between maybe the two departments another $25 million somewhere. I just think that these cuts can really hurt some of these oversight, monitoring, especially air monitoring and health-related matters. So that will be an ask, and maybe just that question, at the end is, will this be something that we can work? I know that we are starting we have a deficit, but I do think that cutting on mental and public health, it can be costly in the long run. So that would be an ask, of finding that. And again, the coordination between the Department of Health and the new Department of Environment, making sure that these positions actually can be worked out to deliver ultimately on oversight.
Thank you. Alderman Robinson, you're next, followed by Alderman Martin. And then our last speaker for the committee is Alderman Mitz.
Chairwoman, thank you very much. Commissioner, good to see you. So two pieces of the puzzle here. Number one, I want to commend Alfonso on your team, as well as Mr. King, who I see in the box, two gentlemen that I regularly have conversations with that continue to do amazing things for your department. And so I just wanted to share that with you. You mentioned getting to zero, which is in 2030. What is the plan in the next 5 years to get there? And then also, why do we continue to see decreases in HIV, but increases as it relates to Black gay men?
Thank you, Alder. So the 90-90-90 is the target that we're hoping to get to. 90% of people knowing their status, 90% of people getting connected to care, and 90% of people staying in care. And we have had a steady decline over the last 40 years to a point where we had about 400 new HIV cases. And then COVID hit and things, started to spike a little because that connection to care became broken. So our hope is that going forward, we can catch up and sustain the progress that we have made. We know now that post-exposure prophylaxis, pre-exposure prophylaxis are so important. Adherence to treatment is so important. But we also know that meeting people's basic need is so important. And that's why housing, our HIV programs do not just provide HIV treatments, they provide housing, they provide support for chronic illnesses, they provide mental health support, they even address substance use needs. So these wraparound services are available, but we don't see as much engagement in some of our communities. And that's what we're trying to figure out. How do we ensure that everyone takes advantage of these services? HIV is one area where we have funding, where we have resources. So the disconnect here is not in the availability of resources, is how do we better engage our community? And so we have looked at the communities that are not as engaged, and that's how we identify the Black gay men, Black transgender men, where we saw an uptick in the number of new infections. How do we ensure we can get more folks engaged in getting PrEP, and what outreach opportunities are there? And Antonio is here. If Antonio would like to say a little more about some of the efforts that we're undertaking to just close the gap there.
Thank you, Commissioner. Before Mr. King speaks, can we utilize our grant money specifically for education, right? A lot of our grant money is very restrictive, particularly to Black-led organizations. And so I hear what you're saying, that we need to more educate this community. Are the grants, are we allowed to do just that?
Some grants. That's not a huge pot of money like what is available for the others. But we do have education activities right now. We are funding 18 organizations to do education and outreach. I think some of the barriers, the folks who are most connected to the communities that can do that work, we have some systemic barriers because our grants are reimbursement models. You do the service and then we pay you after. So there are some organizations that would like to participate, but that is a limitation to them because they have to have the financial liquidity to be able to do the work first and then get reimbursed after the work has been done. And that's one area where we have been really brainstorming about how we can do that. There are some organizations that are coming together as coalitions, but they need that financial cover to be able to do that. Our grants don't allow us to pay people first. It is a reimbursement model, so that's one limitation that we've seen. But in terms of being able to fund organizations for outreach and education, we're able to do that, but it's a very, very small percentage of what we have. Most of what we have is for treatment and housing.
Thank you. Commissioner, are we working alongside of DOH and city colleges and workforce development agencies and also county care? Because what I heard you mention is that we see the numbers increase, particularly in this community, and all of the 1, 2, 3, 4 agencies, right? Workforce, health, even education, housing are all components of this. So are we reaching out to, again, services that we have in the city and the county for a full-on throttle wraparound services?
Yes. We work very closely with county for HIV. They are a primary partner in that space. And we work with federally qualified health center. We have actually explored alternative, not our primary HIV funding, ELC funding, that has allowed us to redirect some funding so that we can engage federally qualified health centers to also be a part of our network from next year. So we are exploring opportunities and avenues to just meet people where they are and not just ask them come to locations that they may not be familiar or comfortable with. So county and FQHCs are some of the partners that we're working with.
Great. Thank you, Commissioner. Mr. King, I have about 3 minutes left.
Well, thank you, Alderman Robinson. Good afternoon. Antonio King, LGBTQ Health and Outreach Liaison. Good afternoon, members of the City Council. Because the highest rate of new infections of HIV is among Black gay men, Black trans, same gender loving men, we have continued and continue to make our program robust and to provide more funding to our delegate agencies as well as our subcontracted agencies and community partners, such as through our community development grants for Chicago Black Gay Men's Caucus, Project Vita, some of the other agencies that are Alliance Care 360. These are agencies whose clientele are specialized in same gender loving Black men, as well as Dr. Ige stated, trans men and trans women. We are working on the west side with Life is Work, another agency in Alderman Mitz's ward, I believe it is, as well as Brave Space Alliance in the Hyde Park area, and on the Project Vita on the Southwest area. What we've done is, outside of the grants that these are funded through those delegate agencies, the community partners that are not part of our directly funded agencies also are eligible for innovative sponsorships, where we provide thousands of dollars for them to continue programming for outreach and testing, as well as screening for STIs through newer agencies on the west side, such as Task Force Prevention Services on Cicero, as well as School of Opulence. These are individual agencies and programs that have a direct contact with same gender loving Black men.
Mr. King, thank you very much. Commissioner, have we given any thought to working with the AIDS Foundation or Northwestern or University of Chicago, some of the large organizations that maybe can take one or two of these Black-led organizations and work with them specifically around funding, right? So the funding is put on the front end, and then the reimbursements on the back end. Again, my thought is that we can work alongside of some of the larger organizations that have the resources, so that way that we can again get to our goal of getting to zero at 2030.
Thank you, Alder. I think those are opportunities for us to explore. Right now, AIDS Foundation does that. They are able to provide that financial cover, and that has been going on for a while. And that way, they're able to support, I think, 18 or so organizations, give them the funding up front, and then when they get paid, they get reimbursed. We haven't yet explored Northwestern and their capacity to do that, but we can also look into if there are other organizations that are ready to provide that kind of fiscal support to the small organizations who are closer to the communities.
Thank you, Commissioner. My last question is, you do not own any of your buildings, correct? You lease?
There are some of our buildings that are city-owned.
Okay. Through the chair, is it possible that you can look at some funding to purchase a building? From my understanding, you need a space for your staff. And so if you look at leasing versus ownership, can you please, through the chair, look at what that cost analysis is for us, please?
We will work with 2FM. They are the lead for leases and build city buildings, but we can get you that information in collaboration with 2FM.
Thank you, Commissioner. Chairwoman, thank you.
Thank you, Alderman. Alderman Martin, followed by Alderman Mitz, and then we'll go to non-members.
Thank you, Chair, and good afternoon, everybody. Wanted to follow up on Alderman Laspada's line of questioning around vacancies. So, and apologies if this was shared and I missed it earlier. How many vacant positions are being proposed to be cut in the proposed budget? From CDPH, of course.
120.
In the 2025 budget, we have a reduction of 124 positions.
Got it.
However, of the corporate positions that we have, because of the hiring freeze, we have 70 vacancies under corporate that are on hold as well.
So 70 positions separate from the 124.
That will be a part of the
It is a part of the 124.
124.
Okay. Through the chair.
No, I'm sorry. Yes, please.
Fakurdi Wagau, First Deputy Commissioner. Alderman, we have a net reduction of 124 positions. the 70 positions, the corporate ones that are on hold with the hiring restriction are part of that 124.
Understood. For those 124 positions, can you provide through the chair the duration of time that each of those positions have been vacant? And just for context, what I'm interested in is getting a little bit more specificity to the point that Alderman Laspada was making about which positions are persistently vacant versus which positions are newly vacant. With the care team, so I'm covered primarily by the 19th Police District. A lot of our residents have been very pleased with the work of the care team. One of the frustrations, nevertheless, that they shared was that for since its inception, it's generally operated just weekdays, 9 to 5 approximately, 9 a.m. to 5 p.m. Are you envisioning in FY 2025 expanding those hours either to go later into the evening and or into the weekend?
Yes, we are looking at expanding hours and duration. Matt, do you want to give specifics?
Can you hear me? Matt Richards, Deputy Commissioner for Behavioral Health. Thank you for the question, Alderman. So we did a labor analysis looking at the most efficient way to expand hours, and basically the most efficient way to do it is to have 2 teams working 4 days a week in each of the districts. So you would have one team working Monday through Thursday, one working Thursday through Sunday. That gets you 7 days a week, and then it extends time in field because they're only working 4 days rather than 5. So that's ultimately the plan. That has to be balanced against expanding districts 2, which is another priority that we have within the constraints of our budget. So we right now have enough funding to essentially operate 10 teams. And so it's finding that balance between how much are we focusing on extending in the districts we're already in versus opening in new districts.
Understood. So fair to say that you have not yet locked in what the potentially expanded shifts would look like in particular districts. You still want to make sure you're filling all those positions that are vacant, and you'll take a look to see the best spread.
Yes, sir. That's correct.
Okay. Can you provide through the chair whether since the CIT officers have left the teams, if there have been any instances in which a member of that team has been assaulted or battered by a member of the public, and then conversely, whether a member of the team is alleged to have assaulted or battered a member of the public?
I do not believe that we've had any such incident. If they're concerned, if our team are on the street and they're concerned about violence, they can call for police support. And we have also worked very closely with the police when they're out on the field and they believe that there is a behavioral health component, and they are able to patch us in. One of the success stories that we have for CARE is that over 1,500 people have been supported, and we have not had to resort to arrest or use of force in less than 1 case, I believe. So I don't believe anyone has been battered or attacked in line of duty.
Yeah, and to be clear, that is both members of the public. What
Correct.
about members of the teams themselves?
That is correct.
Same. Okay, so one to our knowledge. Okay, great. Shifting gears to and this is going back over a year, there was a construction and demolition debris recycling report, an audit that the Office of Inspector General conducted. It found, again, this is over a year ago, that since 2018, CDAPH did not have any personnel dedicated to monitoring commercial and demolition projects. Has that changed? In terms of what you are proposing in FY 2025, will there be any employees who spend at least part of their time monitoring these projects?
That is correct. I believe we have 1 staff position for that now.
Okay, and is that one position, is that part of their overall responsibility or their sole responsibility?
Their sole responsibility.
Okay. The same audit also found that the city had not created a construction and demolition debris management fund, which was required previously by the Environmental Protection and Control Ordinance. Has that fund been created?
Yes. It has.
And how much money approximately do you anticipate the fund will bring in FY 2025?
$500,000.
$500,000. So, and would it be fair to say that that is anticipated based in part on that one position and the work that that individual would be conducting?
That is correct.
Have you given any thought to whether that position, which presumably earns fewer than $500,000 with salary and benefits, should be expanded in numbers? Because I'm thinking, if my math is right, that if we added even just a few more, that could bring in perhaps $1 million or $2 million in additional revenue.
That is correct. Our Office of Environmental Permitting and Inspection needs a lot more hands to be able to meet the needs, and including the construction and debris management. We also do have challenges filling for supervising level staff there, especially environmental engineers, but we have required a lot more people than we have now to be able to meet the demand. And that's something that we've been in conversation with the mayor's office on. We are excited that this year we have an additional 6 positions within our budget for the Office of Environmental Inspection and Permitting. So we are happy with the progress that we've made there.
But will any of those additional people focus on commercial and demolition debris?
Not solely, just the one.
Have you given thought to whether you should have more than one position that could, if the numbers hold, bring in more revenue than it would cost to compensate them?
We can look into it. Our Office of Environmental Permitting and Inspection is considered revenue generating, but we can compare the differences in the revenue potential across the different streams of work.
That one position, is it currently filled?
Yes.
Okay, yeah, I think that would be good, both in this instance and just generally. We're obviously looking under the couch cushions for revenue. And if we have positions that are few in number, but mighty in terms of the amount of resources they're bringing in, I think it would be good for your team to consider where we could responsibly add numbers. Lastly, in March of this year, there was an advisory that the Inspector General's office put out involving the city's complaint-based approach to providing services. So obviously a big advisory. One of the things they found was that per IDPH, Chicago was the only jurisdiction in Illinois that failed to comply with the state's inspection frequency, and that the department, CDPH, is required to submit a corrective plan to IDPH. Approximately when was the most recent corrective plan submitted, and what was IDPH's response?
The corrective plan requires hiring a lot more than we have right now. We get about 5,000 requests for environmental inspections a year, and we process about 2,000 permits. And we also have to be on site doing environmentally complex demolitions and also review permits. So the workload per person right now is huge, and our ability to balance all of that requires almost triple what we have at the moment. So we've been in conversation with Mayor's Office and Office of Budget.
I'm so sorry, I'm going to interrupt you and just ask through the chair if you could provide a summary of what IDPH's response was to your proposed plan, and then if you can also provide how many sanitary positions are currently budgeted and which of those are vacant for FY 2025. Thank you.
Okay. Thank you, Chair. Alderman Mitz. Are there other aldermen that would like to speak before I got you in the next group? Okay, Alderman Cruz, followed by Alderman Cruz, Alderman Mitz, and then Alderman Cruz.
Thank you, Madam Chairman, and good afternoon, Commissioner. You over this way? Let me just start off by saying thank you for coming out to community meeting and visiting with the community, giving us a shock of our lifetime. So now you can just tell me, I never could pronounce the name of that drug that affected the West Side where we all met. I never could. I would try to explain it to someone, but I didn't know the name of it. So just tell me now, how are we looking in terms of slowing down that particular drug, that particular one that's coming into the neighborhood?
Thank you, Alder Smith.
And you can pronounce it if you know how to pronounce it.
Yes, it's methamphetamine. We found
So
that.
you all got that metadonidine?
Yes. Yes, we found methamphetamine for the first time this year, circulating in the West, and we are very happy to say that the numbers has declined. We haven't seen any more of that in the last month or so. There are other ones, nitazine, that we've started to see that we're also working very hard with our intergovernmental task force.
What's nitrazine, if you can give me just a little snapshot of what it do different from?
Yes, these are all animal tranquilizers. They are
Oh.
synthetic drugs. They're just cooked up in the laboratories and pushed into the supply chain. So because we have a community drug surveillance system, where we just continue to check what is in the supply, we keep detecting all this, the new synthetic drugs that are infiltrating our city. And once we detect that, we can mount a response and send out the alert. And we're excited that we're able to control methamphetamine. And now we're looking at what we can do different for the other adulterants.
So then you're working close with the fire departments and the paramedics when the overdose take place?
Yes, we work very closely with fire, making sure that when there is an overdose, there is reversal. And then when people are taken to the emergency department, we are working now to ensure that they get the treatment. This can help reduce withdrawal, reduce craving, and reduce, increase the opportunity for recovery. Because what we're seeing is that people can overdose multiple times because of the craving. So there's medication now that is available that can help reduce the craving, and ensuring that people are introduced on that medication is what we're working on now. And we have seen an increase in the use of that medication, which is why we're now seeing almost 50% reduction in death and 23% reduction in overdose. But we want to bring the number down further, and we're working with fire and our hospital partners.
And I know you're working with a lot of the organization out on the West Side to make sure that they're educated. So maybe that is happening as well. Do you have a number in terms of inspections that's been done in terms from the health department for this year? What's your number? How many inspections?
We have our one-pagers that show the inspections that have been done in each ward. But total number, if you say food inspection, it will be around 15,000 is where we are. I will look up the number for your ward.
Now, when they do the food inspection, are you giving a citation that they have to pay?
Yes, we have
What's the
numbers.
dollar amount for the city for 2024?
I don't know.
We will check that. We track how much income we generate. Again, it doesn't come to CDC, it goes to the city, but we can get those numbers for you.
Yeah, I would like to know what those numbers are, if you don't mind. As we're looking to try to find ways to balance the budget, all cards are on the table here. So we're just looking at that. In terms of a virus can you tell me what virus that is running rapid now? What virus is it that the highest hospitalization? I don't know if that was asked earlier before I came in, but I had to step out.
Yes, it is still COVID.
Yes.
That is the number one cause of hospitalization, followed by flu. It started to tick up around June. It's on the downward now, so we're happy about that. And we're happy to say at least 30% of our seniors have gotten their vaccines. So we want that number to be towards 70%. So we have a number of vaccination clinics, about 200 scheduled before the end of the year, to get the numbers up. And things are moving along. Dr. Sloboda?
Hello.
Yes.
Hi, I'm Dr. Alex Sloboda. I'm the Medical Director of Immunizations and Emergency Preparedness for CDPH. And so, yeah, we've scheduled or have completed over 200 vaccination events throughout the city of Chicago, including 47 wards so far. So thank you all for working with us to put on those ward events. They've been very successful. And we've also, at those award events, we've had an increase in vaccination compared to last year, which we're really excited about. At the ward events, it's a 12% increase in doses compared to last year. And overall for all of our events, a 20% increase. So we're really excited about that. Was there another specific question or?
That's all. It's mostly COVID and
Thank you.
flu that are the major causes of hospitalization. So we want people to get both, and we're very excited to see that the numbers are much better this year than last year.
I just feel that there's still a lot of the covert that's still running out here, but I don't hear enough of preventing the covert. So I don't know, is it something I'm missing, or if it's more of a educational again that we need to be pushing on this. But is there a certain time you wear your mask again, that when the peak come up?
Yes, we continue to encourage people to wear their masks, especially if they're 65 and older, and if they're going to be going into a crowded space indoors, and if they have chronic illnesses. High blood pressure and diabetes are the commonest comorbidities that have led to increased hospitalization. So we encourage folks who are at a higher risk of severe illness to continue to wear their masks if they're going to be in places that are crowded. Vaccination continues to be the most effective tool. I keep telling people that, there was a time where we were seeing 800 deaths, and over the last month or so, we haven't had any deaths from COVID. And that is because there is higher level of protection now and immunity. So we don't want to take our eyes off of that and go back.
Let me get to another question. I'm watching the clock. That flood that happened in my community, and we talked to you about this when we came out and told you it was a health issue. Have you visited any of those homes, or anyone from your department visit anyone out there? In fact, you got a young lady in the hospital now that her lungs collapsed last week just from mold still being in the homes, and that is a health issue.
Yes, thank you, Alderwoman. Yes, I did follow up on that. The Department of Buildings, I believe, got an additional 1 million to respond to the mold issues. I believe they will have some detail on if that work has already begun. And our work in CDPH, we now, through city funding, now have opportunity to also address mold as well as lead. So we are primarily in the lead remediation space, but additional funding from the city now allows us to do more than lead when we're in homes. So that will start next.
Well, now that stays in the budget. So we're gonna work together so we can see how we can bring these departments, because it seems like people are working in different spaces.
Right.
And it's not coming together as a whole for the community. So if you don't mind working with me, and let's see what we can do.
Will do.
Thank you, Madam Chairman. I didn't want to run up my time, but I had to get that part in.
Thank you.
And thank you all for all your work you're doing. Keep up the work.
Thank you. Alderman Vasquez?
Thank you very much, Madam Chair. Thank you so much for being here. In order to make the most of the time, I'm just going to go into questions. Thank you. Okay. So a comparison of payroll data and the 2024 budget shows that inspections and permitting was allocated 26 full-time positions. As of September, 9 of them are vacant. 1 attorney, 6 environmental engineers, a senior environmental inspector, and a supervising environmental inspector. Roughly 1 in 3 positions allocated for environmental inspections and permitting aren't filled right now.
Right.
What is preventing it from being fully staffed?
It has been quite challenging to get accepted offers. We have interviewed, we have made offers have been rejected. Environmental attorney, supervising sanitarian, their salary compression issues. We are working with the Department of Human Resources for what we can do different, but these are positions that they are on a list of our hard to fill positions that we're working with DHR on.
So to understand it, it's basically competitive and we're not competitive with the
That is
market.
correct.
Okay. Last year, the city awarded asphalt contracts worth several $100 million. Those contracts specifically allow the Commissioner for Public Health to request post-award documentation from the winning vendors, including a traffic study, an air quality impact study, a fugitive emissions control plan for continuous fence line monitoring of pollution. But according to local reporting, they have not been requested as far as that post-award documentation. It seems like this might be an easy way for the city to get important data about the environmental impact of the city projects. And it's also budget neutral with the cost of the studies paid by vendors that won multi-million-dollar contracts. Can you discuss why the department hasn't requested this documentation from the winning vendors? And if you commit to working with us to formally request that documentation?
I will follow up on that and get details. To the best of my knowledge, CDPA does not have authority to request those documents, but if there is documentation saying that we're required to, then I will follow up on that. It was before my time, but I will look into it.
Yeah, I think a follow-up to that is, if it is the case that you're not able to request it, then who is, if there is the post-award documentation? Because we want to make sure that a lot of folks who are getting all the city money are being held accountable to results as well. So yeah, if you could send that, that'd be greatly appreciated. Okay, as the pilot care teams are being provisioned, how are they being connected to the coordinated entry system for unhoused people currently? And what is the plan to train and engage them with the One System initiative, as these mental health first responders are sure to interact with many unhoused people in the regular course of their work? So for example, in the 40th Ward, we're doing a conversion to create non-congregate shelter on Lincoln. And when we were told about the process, it's the CARES team that they're going to interact with. And similarly, as we're moving to One System initiative, like how are they going to be brought up to speed as to what that's going to look like?
Yes, so our team, behavioral health team, is closely connected to all of those, we call them resources and support services. So when we interact with people during our outreach, many of them need housing or shelter. The way the shelter system works right now, if someone requires shelter, they have to go into the coordinated entry and be on the wait list. So our teams are trained to refer people to whatever local services are available. There are some services that are not connected to coordinated entry. Most are. And so we refer them to how they can get shelter. If there are available beds in anywhere, we will refer them there. But many times there are no available beds and they have to go in through the coordinated entry and be on the wait list there. So they are in tune with how the systems work.
I appreciate you saying that, because I think something that's probably for another department that we're going to ask is, we've got the funding for beds, and that's only 6,800 beds. And then we're going to do rapid rehousing, but if the beds are maxed out, where are we rapid rehousing to? And I think I appreciate that that's kind of some of the challenge you're seeing as well. So next one, I've asked this before, and there hasn't seemed to have been a lot of movement on it. If a city contractor is cited for breaking an environmental law, how does CDPH communicate that to the Department of Procurement Services? Can you, like, how are they basically held accountable, right? If you got to talk to procurement, what does that look like? And why we haven't collected money from people that have been violating on those, because it is revenue, and also we want to curb that behavior.
This is one area we will discuss with the Department of Procurement Services. It's not been a part of the scope of our work in the past, overseeing or regulating contractors to the city. But we will look, that's come up also, Alder Sicho Lopez has also flagged that, and we will look into that and see where there might be opportunities for us to collaborate.
Yeah, I think the challenge there is, we asked this question last year, we still haven't gotten a response. And so asking it this year and say, we're going to look into it, like what I don't want is coming back next year saying, we're going to look into it some more. Who's the person to contact? Who's the best person to hold accountable? That would be the one that would then reach out to procurement. Is there someone on the team who would be like the point for that?
I believe the transition in leadership might have contributed to that. Now we have a commissioner in CDPH and there is a commissioner in DPS, and I will follow up.
Okay, yeah, and we'll follow up with both, because I think sometimes it's just syncing everybody together. Okay. Okay. There was a CDPH staffer who presented last week at the city's advisory board of health around CDPH's highly anticipated air monitoring plan. There was some contentious discussion with Pastor Smith on the board, who did not see this as a useful focus of the CDPH's resources. Since that meeting, this employee no longer works for CDPH, and I guess it is rumored that Pastor Smith will be elevated to the board's new president. Does CDPH consider this air monitoring project a necessary use of city funds? And will you be proceeding with this project that environmental justice groups are relying on?
That is correct. The air monitoring work will continue. And we will assign staff to ensure that the work continues.
Okay. The other thing we'd like to know is who the language access coordinator is for the department, to provide a breakdown on language access services used in 2024 as well as plan for 2025. We've been doing work just across the city trying to get language access improved. It is abysmal, and even though we've got the language line contract, which I think hasn't been fully re-signed. And so just wanted to know what the plan is for CDPH, knowing that we're talking about communities on the southeast side, for example, where you're going to need Spanish translation to get more information. So what's the plan for language access?
The language access line is coordinated by our public information officer. That's the central coordinator. But we're very proud to say that 33% of CDPH staff speak Spanish. Over 36 languages are spoken. So in all of our clinics, they're Spanish speakers. So we haven't had to depend on that as much, but we have it as a resource and it's coordinated by a public information officer. But our communication team also includes a number of Spanish speakers.
And then, yeah, if you could through the chair also give a breakdown, like you mentioned 36 languages and kind of percentages. I think knowing that would be really helpful because some departments don't have that much. And so to know that is actually a really good thing. How does CDPH plan to continue to expand its efforts around addressing the issue of extreme heat and urban heat islands in Chicago? We have pending legislation for outdoor workers that seems more pressing to get passed now, especially given the election results and knowing that there's maybe not the emphasis needed on the environment and with the incoming administration. Would you support passage of legislation that would support the outdoor workers? And is there a plan for like addressing some of the extreme heat and urban heat islands in Chicago?
Yes, we've been working very closely with the CDC around the impact of heat on health. So we have robust data. We also have partnered with Elevate Chicago to document the impacts and recommendations from communities about what options there are. I believe the operational implications and the resources that are necessary for us to fully live into that is where we need to really better articulate how do we mobilize the resources that we need to make this happen. But in terms of the impact of heat and what work that needs to be done to protect our community, we have been at the forefront of that for many years, collecting the data. The resources that are necessary to start implementing those recommendations is where we need to explore options.
Okay, thank you. And last question I have, and I'm sure it's been asked before, but I think through the chair is kind of what would be helpful to us is the department's largely grant funded. I mean, we all know that. This incoming administration, if it was looking to attack, for lack of a better word, it would gut funding across the board. And so any information you could provide to us that's funding, that's programmatic, that's policy-wise, that we can start looking at in advance of what could be coming would be extremely helpful. I'm also very concerned about any data or identity collection that the department might have if the federal government decides to start moving. So any protections that you all would recommend, if you could send through the chair, we'd greatly appreciate it. Thank you so much. Thank you. Thank you, Chairwoman.
Thank you. Our non-members, Alderman Taylor, followed by Alderman Hoppenworth and Alderman Beal and Alderman Cruz.
Thank you, Chairwoman. I heard you say that the COVID numbers went back up and then they're slowly going down. I didn't, there was nothing sent to our offices. I didn't see on TV. None of that happened. I'm gonna say to you what I said to Dr. Owadi. I do appreciate the work that you do. Sometimes it ain't about being vaccinated. Sometimes it's about how do we eat healthy, things that we could eat, things that we could take. Medicine is very expensive. And so I want to see you all do a better job and use the access to the advertisement, the TV, because Dr. Owadi during COVID was on TV every day. And I said to her the exact same thing, and I'm gonna challenge you that on every budget about us talking about not just being vaccinated, us talking about being healthier, us taking care of ourselves in a better way, because there are plenty of people in our communities that are not gonna get vaccinated. They're just not. And so how are we teaching them to take care of themselves? I never saw the mask mandate go back in. And so I don't want us to get away from, because we're not on COVID punishment, and that's just what I call it, that we're still not being COVID conscious. Can you talk about that?
Yes, COVID funding allowed us to do a lot of work. If we had the same kind of funding for all of our programs, we will have seen a lot of progress. COVID funding is very restrictive to COVID. You can only talk about COVID, and you can only talk about, so these are some of the restrictions that come with federal dollars. Chronic disease, like we have identified, is the primary cause of death in Chicago. And that's related to food and access to health services. Right now, grants funding does not include anything that allows us to do chronic disease prevention writ large. So these are some of the limitations we have. We are looking at how we can do a better job engaging. And one of the opportunities we're exploring now is collaboration with the network of health service providers. They are doing food as medicine. And what we are doing is providing them data. These are the communities that we want you to focus on based on the data that we have. There are state partners that are now being contracted to work on health equity. We are sharing data with them and say, these are the communities that are most impacted. They're not giving us the funding, but we are contributing, helping them to prioritize how communities can get better access to food and get better access to physical activity and get connected to the services that they need. So it is true. We need to do more than talk about vaccination. And the reason we have just talked about vaccination is because those are the requirements of the federal funding that we have.
So the requirements say you have to push the vaccination and nothing else?
That we can use funding to educate around vaccination and COVID prevention writ large. And our COVID prevention strategies include masks and washing your hands and other clean air, etc. But vaccination continues to be the #1 way to protect communities.
At some point, I want to have a conversation with you about us just pushing medicine and vaccination, because that's not working for a lot of people.
I know.
You wind up on the medicine 20, 30 years and nothing changes your body. I'm not going to beat a dead horse about the HIV, but are you all noticing that the number of Black women, the HIV numbers are going up? And can you give us that ward by ward? Same thing with the COVID numbers. I want to see ward by ward, the COVID numbers and COVID deaths.
Yes.
Because we never kind of unpack that during COVID time. And I know now we're starting to see more people go back into the hospital because of COVID. My other question is, how are you all working with the EPA to hold the railroads accountable? I probably got 1, 2, 3, 4 railroad land takeovers in my ward, and I'm starting to see the number of bronchitis and asthma go up in folks who live around that. How are you all holding them accountable? Because what we have is trucks that idle down the streets. So literally the railroad is by a school. They literally have trucks who idle for hours in the street. That's polluting the air. You have trains in that same community that idle in our community and are polluting the air. And there's never been, and I had this problem with Awadi, and I hope I don't have it with you, that there is no accountability, there's no talking to nobody, and I'm literally told I gotta go to the feds. That ain't my job. I work for the city, and I want to be able to work with you all to say how we holding them accountable, how we making sure that their trucks are not lining up our streets and just idling for hours until they could check in. And I ain't telling you what I think because I don't live too far from it. I'm telling you what I know.
Emissions from transportation, I believe, is one of the areas that we identified as contributing to the environmental impact. So we have been working with the Department of Transportation, Department of Environment around what the recommendations can be for the city in terms of regulatory authority. The environment right now, it is the National Ambient Air Quality Standards is set at the national level. States are required to comply, and then cities are required to comply. So the Department of Transportation will oversee like transportation related. We oversee industry related, like large recycling plants. But we have been part of the conversation in terms of documenting the impact of all of these emissions. And then the next step is what policies need to be enacted to hold folks accountable. We can't hold people accountable without the policy. There has to be the policy first, and then we then go and enforce the policy. But for transportation, it will be the Department of Transportation.
So I'm gonna challenge them. As a matter of fact, I'm gonna put you all both on the email because their recommendation to me was to take money out of my menu to put signs on those streets to tell trucks, you can't idle down these residential streets. So I'm gonna take money that I can get my sidewalks done, I'm gonna get my streets done to say that you can't idle your trucks here. That doesn't seem fair to me and my community. CDPH needs to take responsibility along with CDOT to have some type of regulations and to work and say, what's the ordinance? What's the work that we're doing to hold them accountable? Because I'm not doing that. I'm just not. And they get more money through the federal government. I wasn't in office when Norfolk Southern took over Inglewood. Now I'm dealing with what we didn't take care of. And so they're not even making sure that they follow the RDA. And so who helps me hold them accountable? Because that last administration did nothing, and I don't want to call nobody out, but I will. And so I don't want to be in a position where I got to answer to my community about why the trucks get to do this, why the trucks get to do that. Can you, through the chair, look at the last 4 years of bronchitis and asthma cases ward by ward that have went up since forever, because they've been there longer than I have, and they continue to expand, which I have no say-so in it. So it's funny they're allowed to expand and take over communities, but then when it comes to accountability of the community getting sick, I'm left holding the bag. STIs in senior buildings. How are you all working with, I got 18 senior buildings, I had 22. And the one thing that I know for sure is the STI numbers are very high. How are you all working with automatic offices and senior buildings to make sure that we're talking to seniors about using protection?
I will follow up with you on that. We get notification of infections that are occurring in the city. And so we will look into the data and see what is going on there and work with your ward on how we can address that.
So through the chair, I would like to see the number of STI per wards that we're kind of looking at, because those numbers, according to, I want to say the dashboard that I'm looking at, during the summertime, they seem to be very high. Then in the winter, they seem to be very low. But I want to talk about how we're educating. How do you all deal with businesses who sell food who aren't supposed to and the community gets sick? How do you all coordinate with BACP?
We get reports through routes 311. If we get a complaint, we are obligated to go out and check it out and see what is going on. There are standards for mobile food. When those standards are not met, BACP and us can go out and enforce. Folks are not supposed to be selling hot food or cooked food that is not prepackaged to reduce the impact of contamination. And if that is going on, then BACP or us can go out and, enforce that. So there are standards for push carts, there are standards for mobile vending when it comes to food. Now, if there are foodborne outbreaks, we also investigate to find out the source. Sometimes it is food vendors, and that also we investigate and respond.
You all need to do a better job to go out with BACP at those vendors that set up. They don't have editor's license. They selling food, and then you got a community full of folks that are sick because they don't have access to running water, or they are selling food that they're not supposed to be selling. Thank you, Chairwoman.
Thank you. Alderman Lawson, do you have questions?
I'll be brief. Thank you very much. And I just want to piggyback on what Alderwoman Taylor was saying. We have an issue that we've been working with CDPH, BACP, fire, and police of people who have never been licensed and can't be for the food operations, and they're just cooking on the street. I introduced an ordinance actually last week to go after the propane, which may be the most dangerous. In addition to salmonella, of course, a propane tank exploding is a real problem. So we need your help on that because people are going to get sick, people are going to get injured, and it's a citywide issue, clearly. Most of my questions have been asked and answered. I'm a proponent of LGBT health, obviously, and I want to thank Antonio and all the work that you guys are doing there. I really wanted to thank you, though, Dr. Ige. You and I were at Getting to Zero 2.0 together, and I had never heard you speak maybe on HIV or speak so passionately. And I really appreciated your remarks, your experience in this field. Maybe just, and again, this will be my only question. Talk a little bit about 2.0, what that looks like, how that's being impacted in our budget and our partnership with the state and the county.
Yes, it's one of the most exciting areas of my work, just the thought that we can actually get to zero in my lifetime. It is quite emotional for me. And we know that it is now possible because now we have less than 600 new HIV cases, and our hope is to get that number to zero. So we have been working with state and county very closely to better deploy the resources that we have. One thing that is innovative is not just looking at those who are living with HIV, but those who are vulnerable to HIV and making sure that it is wraparound. The concept of syndemic started with HIV. We're not just looking at HIV alone, but all of the other social factors that can impact people. So this is where we want to concentrate our effort. I've challenged my team. We have to get to zero. We want to be able to do that in a way that is equitable. So we are working with our partners to see where can we do better. So we're open to feedback, from you, Alderman. Where are there opportunities for us to collaborate and do an even better job? But we must get to zero, and now we can see the light at the end of the tunnel.
Thank you. I appreciate it. That's it, Madam Vice Chair.
Thank you, Alderman Lawson. Next, we are going to have Alderwoman Mana Hoppenworth.
There was something that I wanted to.
Thank you, Chair.
Oh, hold on one second. Can you hold her time for a second? Go ahead.
I just want to make a correction on record about the mold remediation. It is not in the Department of Buildings. That information will be provided about the department that is leading the work.
Okay. Say that one more time.
She said.
Do you know which department? It's department.
Mayor's IGA will provide that information. Jen?
We just know
Jen
it's not-
Vitis? Yes, we also do some mold work. Jen Vitis? When will that start?
I'm Jen Vitis, Deputy Commissioner, Chief Program Officer at CDPH. And the question is about work we're
Mold?
doing with respect to mold.
Yes.
Yes. So the department has funding. Well, it's through our lead poisoning prevention, early childhood and healthy homes program. And we've got a mix of funding from HUD. It's largely responding to reported cases of lead poisoning in children. But when we have reports of those cases, or when we have community members reach out to us because they have concerns about lead and other health hazards in their home, if they're eligible for the funding that we have available from from HUD, excuse me, and now expanded funding that we have, thanks to City Council and to the administration through bond funding, we are able to do pretty extensive work in homes that addresses not just lead hazards that may be found there, but mold and other health hazards in the home.
Yes. So the difference is that CDPH, our entry point is lead, but if there is mold as well as lead, we're able to support. Is that correct, Jen?
That's correct. Thank you.
Alderwoman Mitz.
Yes, thank you. Can we have that information? Now, you all know I'm very serious about this, and I don't want to be playing. We got some money mess around. We have people in my community who are dying. I don't need to be playing around from one department to another. I just want to get the money together so that we can help folks.
We will work.
You all will reach out to me for that.
Will do.
Thank you.
Thank you. Alderwoman Manal Hoppenworth.
Thank you, Vice Chair. Hi, Commissioner. I had a question about the CARES program. Is it still a pilot?
I will not describe it as a pilot. We tested this model. We know that it works. So the concept is proven. We are testing out a new model, which is public health led model, which is a different expression of the work that we've done in the last 2 years. So in some way, it is a new expression of the work, but it is no longer a concept that needs to be proven or a pilot in the traditional sense.
Okay, and that was funded through ARPA?
That's correct.
And so this new program will not be funded by ARPA?
We are working on what the pathways for sustainability will be. Right now, the program is on ARPA until
Okay.
2026.
I do want to say that I support the program, but we're in Edgewater, 48th Ward, so it's wedged between two communities that receive access to the program as it is right now. So we don't get it. We have a lot of need in our area, and so I would like to see it expanded, and I was just curious about the movement forward for that.
Right. One of the options that we are exploring with this new model is a citywide team. So some districts may be able to have dedicated teams if they have high numbers of 911 calls, but the rest of the city will have a citywide team, and that way we can serve the entire city and no longer just be restricted to a few districts.
Thanks. In addition to the mental health needs that we have in our ward, we also have issues around substance abuse. So I was curious to know, related to the opioid and
Guys,
settlement
can we
funds.
just have you quiet down just a little bit? Thank you.
Thank you. Related to the opioid and settlement funds, how are you all doing to meet your objectives, and how are you measuring success?
Yes, so we want to harm reduction and prevent overdoses, especially death from overdoses is one of our core goals. And to do that, overdose reversal naloxone, just making sure the city is saturated with that. So all public libraries, we have vending machines, all schools, community partners, aldermanic offices, whoever wants naloxone, we want them to be able to get it. And in some communities where numbers are high, we're actually doing door-to-door distribution. So that's our main strategy. The second main strategy is the medication for substance use disorder. That medication is available through telemedicine. You don't need to go into a hospital. You just need to call the number and it will be delivered to you. And the numbers there has been low. So we've been really educating about this option. What this medication does is reduce withdrawal and reduce craving. So we want people to use it. So that's the second strategy. And then the third strategy is just education, letting people know what a substance use disorder is. It alters your ability to self-regulate. So folks need support and need treatment, and encouraging loved ones, family members to ask for help. We have a number, we have a hotline. If there are folks who need our support, please call us and we will respond.
Thank you. And we are an aldermanic office that participates in the Narcan program, so thank you for that. Related to staffing adjustments for expanded, so you all do so much,
With increased funding for mental health and community response program, there are expansions in associated staffing. How are you balancing the need for additional staff with budget constraints? And are there plans to explore more partnerships as a cost-effective alternative? How does that work for you?
Yes, this is our primary strategy for sustainability. Again, we were very aware that this is one-time funding. This is not recurrent funding. So part of our sustainability plan from the get-go is building partnerships to ensure that these programs or services can continue to be available. And we're doing that for violence prevention, collaborating with county. We're doing that for mental health. There's now more federal infusion of funding. There's county. We're collaborating with county. We have regular meetings now to coordinate. We're doing that for opioid prevention. We have an intergovernmental task force. We're doing that for behavioral crisis response. There's now a behavioral crisis hub. So we are working to synergize and again, making it clear that this responsibility should not just be on the city of Chicago. We need all tiers of government to support this work. And so that is the work that we're doing right now to ensure that our community continues to get services even after COVID era funding expires.
Thank you for that. I appreciate it. And does that also include the violence prevention? Does that also include gun violence prevention?
That is correct.
Because we've had such a high number of incidents of gun violence associated with our youth around our schools. And so I appreciate the work around that. I had one more question about, we talked a lot about enforcement. So I was just curious how much of your work is around enforcement related to environmental issues?
A lot of our work, I have numbers for the inspections that we do, but we get a lot of 311 requests. To date, more than 7,500 requests for environmental or food-related inspections. So it is a huge part of our work. So sometimes we go out and there is violation and we issue citations. We will get you the numbers of how much revenue we get from that. But enforcement is a huge part of our work for both food and environment. In environment, the issues relate to emissions or chemical or radiological hazards. But emissions is really where people are most worried about, especially dust, and that's particulate matter oversight. So that's a huge part of our work.
I'm just wondering, and I don't know where this conversation could happen because I feel like it needs a little bit more attention. How much of your work can be shared with our new Department of Environment? Because I feel like I've heard several times today that you're having trouble filling really important roles towards this end of enforcement. And I need to look into the history of the Department of Environment, but can you speak a little bit on that? Like, is this a new thing for your department that you have taken on?
It is not a new thing. There is environmental public health, and environmental public health is focused on environmental hazards that have a public health impact, lead, asbestos, air pollution, etc. That's a part of public health work and part of our accreditation requirements. The Department of Health, Environment, I believe there is a plan now, and the scope of the work, we work very closely, is being defined. But currently, oversight of public health related hazards, food, air, environmental hazards falls within CDPH. The challenge we have recruiting is also the general challenge we have with the healthcare workforce and public health workforce. Those who are inspectors are environmental engineers. It is a, secondary degree. A lot of certification is required. We have looked at different opportunities for how we can recruit people and retain people. Compensation is one of our biggest barriers. There are salary compression issues. their retention issues. Again,
Yes, I remember hearing about that earlier.
so
That's very
it's been a
hard.
long-standing problem.
I hope we can consider as a city, like how to spread the work. It's a very important thing, you know, enforcement is very important. It's important for the health of everyone. And if we have these, like you say, we have these policies, but we're not able to enforce them, that's our failure. And that's 80% of the time that policies fail is because we can't actually implement them. And it sounds to me that we're not able to do that because we're always short on staff. And so I just wonder if it's just a marketing thing. What if it was marketed through a different department, but it's the same work? I don't know.
Yes.
But I just want to appreciate you and your work. You all do so much around mental health, around substance abuse, you know, around the environment. It's a lot, and I am worried, as many of my neighbors are, about what's going to happen in the next 4 years under a new president. What kind of regulations are going to be lifted. And so I just call upon you to work with us to figure out ways that we can show the city that we are working together to protect everyone, including the rights of living in a community that has clean air, water. So please, I hope that we can continue to work together. Thank you. Thanks, Chair.
Thank you, Alderwoman Manaha-Hoppenworth. I just have a couple follow-up questions to chime in here. Dr. Ige, you mentioned regarding the CARE program that we're working towards citywide coverage. Do we think we're going to arrive to that place in 2025? I know that the pilot was in certain areas, and I know that we're growing that at this point. And obviously, the wards or the districts that have the most need should have the most consistent care. But like Alderwoman Manaha-Hoppenworth, I don't necessarily live in one of those areas. I know that there are several of us that sort of fall into this category where our problems are not severe enough or frequent enough that those resources are super readily available. So I'm curious about the timing for citywide coverage.
Yes, we are hoping to roll that out by 2025, January. Our staff have been hired. We have 10 teams now. They are completing their trainings, and we hope that we'll be able to launch in January.
Great, thank you. And then you mentioned requests from 311 for inspections. Did you say 7,500?
Yes,
That's so far this year?
just this year.
Okay. What's and through the chair is fine, but what's the average time from like receipt of the 311 report to actual inspection? I guess it
80
depends on the.
Yes.
Yeah.
Most of our environmental inspections will respond within 2 days, but 88% of our 311 requests will respond within 7 days.
Okay.
There are some requests that are harder to respond to, like the volume of the mobile or push card. There are a lot. So those take us much longer to get to just because of the volume of other requests that we have to deal with. So we're working up with BACP on how to accelerate response times there, or where we can collaborate, like Alderwoman Hoppenworth was talking about, because the demand for service is quite high, and the staffing that we have, there are so many different
It's
requests.
challenging, I know, across every department. I wasn't here earlier, so I apologize if this has already been asked. Has anybody asked for, through the chair, a list of violations by ward with citation dollars that have been collected?
We can get that information. I will, by ward. We can track by ward. Yes,
Great.
we
Yeah,
have
through
a
the
list
chair
of
would be great.
Right.
And then I'll go to our last two questions, Alderman Beal and then Alderman Cruz.
Thank you, Madam Chair. I just got a couple of questions. Before I start, I just wanted to also thank you for coming out. We did do an outreach COVID expo service fair out in my ward, and you graced us with your presence. I appreciate that. It was a great event, and a lot of people got some shots that day. So, and I was one of them. So,
Thank you.
all right. You know, this predates you, but I want to see if you can kind of research and maybe reevaluate the permit that was denied for political reasons for the recycling facility out in the far south side. I think that right now the city of Chicago has an exposure of about maybe close to probably $400 million worth of lawsuits that we could potentially be exposed for because we played politics with a company that spent $100 million for a recycling facility on the far south side. And they spent 10 extra million under the direction of the city of Chicago at the time. Again, this was predating you. This is the past administration. But this company spent $10 million extra because they wanted to go above and beyond what the requirements were to make sure that their building was environmentally safe as far as emissions and everything else. And they followed the lead of the law department. They followed the lead of the department. They did all the right permitting. They did everything right. But then at the 12th hour, they were denied for political reasons. And I think it's going through the court process, but your department was the one that denied it. And I'm asking you to look into it and review it because eventually we're going to lose that lawsuit. And they're going to come back and they're going to sue the city and they're going to win. And we're going to be on the hook for probably $400 million for political reasons. And so I'm asking you to go back, review it and look at it and do the right thing and minimize the exposure that we're going to have, because at the end of the day, it's going to come to this body and we're going to have to sign off on a new bond to pay a huge lawsuit that it could have been avoided, but the past administration saw fit to play politics right before an election to deny that permit. And I think it's wrong, and I think we're going to be exposed, and hopefully you can look at it and, again, review it and see if you can minimize the exposure, because I'm warning everybody in this body right now, we're going to be on the hook for over $400 million if we don't do something right now and settle and minimize the damages. So that's all I have for you, but thank you so much, and I appreciate everything that you all are doing to help continue to keep our city healthy. Thank you.
Thanks, Alderman Beal. We're going to go to Alderwoman Cruz, and then we're going to wrap up with Alderman Hall if there are no other speakers. Alderwoman Cruz.
Thank you, Vice Chair. I want to start off by giving a special shout out to somebody who is always from your department willing to help us. He goes above and beyond to troubleshoot, and that's Alfonso. So we always can, I say he's my lifeline. I can always call him, and he is always a great of service. It's something that, I want to bring up to your attention and really share my sentiments and my disappointment with your department is when we encounter a mental health situation in my ward. I was at a point begging for assistance. And it wasn't to be there to provide information about an individual. It wasn't to do anything besides really listening and being there for my community who had been asking for help regarding the situation for quite some time already. And again, it was just disappointing that I was just begging for one of your staffers to be there. Eventually, we were able to get someone, and she was wonderful. She was what we were looking for. Somebody who had the experience, somebody who can talk to the community, explain how complex the situation was. But again, it took a lot. It took a lot for us to get there. And, when we talk about mental health, it's not only the individual who's unfortunately going through, but also affects the community. Until this day, we don't have a solution. Until this day, the situation is still happening. I sent an email a couple months ago, about 2 months ago to be exact. The response was, we'll get to you by the end of the week. It never happened. 2 months later, and I still haven't heard back. But I hope those things changes. And to my point about mental health, let me ask you this. I know there's a proposed budget allocating $20.18 million for mental health. Could an increase in the funding allow the department to further expand beyond the current 7 city-run clinics and offer accessible trauma-informed services in neighborhoods facing highest levels of crisis calls?
Thank you, Alderwoman, and I will follow up with my team on that incident. I was aware that we responded, so I will follow up and see where things got lost in transition. On mental health services, we have been really exploring solutions for how we can meet the needs of our community. Brick and mortar options are one of the options available. Brick and mortar options also come at a high cost, and especially now where there's just constraints on every side. So the first step in addressing that is how can we bring services to where we already have services as a first step? Are there opportunities to do more? Yes, and some of those we have been exploring. How do we take services to people's home when we're visiting them with our public health nurses, schools, public library, other options that are not as cost intensive? Then how do we contribute to services that already exist as a federal regulation to integrate services rather than have standalone mental health services? So we are continuing to explore that. What will be possible in the future will depend on the resources that we have available, but we don't want to wait and limit our options to just brick and mortar. So we are exploring all options, including partnership with our other tiers of government. Behavioral crisis is also the same. We just heard that the state is funding some organizations to provide crisis response. We are also doing crisis response. We now have an intergovernmental agreement with them. How can we collaborate and ensure citywide coverage? So where we are and they are not, where they are and we are not, so that we can ensure citywide coverage. So these are some of the strategies we're exploring, knowing that the city alone cannot solve for all the problems. And so where can we partner and synergize to ensure services are available? So those are some of the things that we're doing now. We will be open to doing more. Resources are limited, as you know, for all departments. So we are trying to be creative in our solutions.
Thank you. I know one of our state representatives, Lindsay LaPointe, from the Northwest side, and myself, we're looking at how we can transform some of these things into a wraparound services, and how do we combine city with state. But let me ask you this, and this might be an option, may not be. I'm not really sure. But as we talk about other funds, and you talked about it's hard because of funds. Is there any such a thing as like the opiate settlement funds? Can that be used as funds for low barrier housing with supported services?
Some options exist, but the opioid settlement fund is also limited. The volume of need there in itself is huge. Opioid overdoses, death related to opioid overdoses right now exceeds gun violence plus road traffic accident combined. So the likelihood that we can use opioid fund for other things is limited because the need in opioid response also is so huge and it's all over the city. Yeah. So we are exploring options, but it's not likely to be a huge pot of funding for additional services.
Makes sense. And, as you talked about, like, it's huge, those numbers are huge. And it seems that Chicago last year saw an increase of like 15%. And to that extent, how could additional resources be used to expand substance use preventions and treatments across the city?
Yes, and that's the primary use of the opioid settlement dollars right now. Just expanding the opioid response programs. And we were very excited about the progress we made this summer and that we have brought that down by 23% because of some of the activities. And we hope to even bring it down further. The naloxone saturation plan, the medication plan, the recovery support services. And we're now exploring the synergy between mental health and substance use disorders so that in our clinics, addiction services and other support services can be provided as well.
Real quick, I'm looking at my time. Another question, and I'm going to ask it from this book we have right here for the MBEs and WEs contract data. There's a significant drop. I mean, it's a huge drop from, year to year till this day for Hispanic and MWBEs. Can you tell me, is there a particular reason, like what happened from one year to the next?
Yes, the funding, our grant funding has been slowly going down. So you will see also the decline in our professional and contract services as well. The specific around MWBE for Hispanic communities, I will look into that or additional data. But during COVID, we were not really hitting any of our targets for MWBE at all. And that was because we're moving so fast. Many of the contractors and professional services were not eligible for that designation. And the federal dollars did not allow us to designate funding that way. So we were not meeting those targets. We are doing a better job now that we're out of that emergency mode. And so I will look into it again and see what factors
'Cause
contributed to that and what we can
The
do different.
the significant decrease is only for Hispanics. So just
I'll look
wondering
into that,
on that. But one more question. I also want to give you, last year with the daycare centers, between the total request and the average day time, I see like there's a huge improvement. Last year, the average days was 308. This year, we're at 45 days. So I think that's huge. What changed?
We have been paying a lot of attention to our process improvement and just looking at customer service overall as a priority for CDPH this year. That is a priority for me. We want people's experience of government to be positive and we want to be responsive. So we have looked at all of the barriers that we have. How can we be a bit more efficient? How can we respond faster? So we are continuing to clean up. Our major limitation is just staffing and our ability to get through all of the requests that we have. But we are doing a better job with expediting manual processes for our permitting and other activities so that people can respond faster to the 311 requests.
Thank you.
You good? Just one quick follow-up from the MBWBE question. I understand that during COVID, you were moving at such a fast pace and only certain vendors qualified. Knowing that now, what have we done? And you can, if you don't have the answer, we can get this through the chair, but I'm wondering what we're doing to better equip or build capacity in those same vendors so that they're not in that position again, should something else happen.
These are areas where we've been, Mary, do you want to say something?
Mary Manuel, Deputy Commissioner for Finance, Grants and Contracts, and also the Chief Financial Officer. So, just to give some context into this, we were not meeting that goals before because there were a number of factors there. It was because of COVID, the practicality of going through contracts. It was also because we did receive waivers from DPS. It was also because some contracts were not MBE, WBE eligible. So keeping in mind all those factors, we have been working with the department, the DPS procurement department, to make sure that we do align with the requirements of MBE, WBE requirements. And so the goal here is to make sure that we have vendors who also meet with those compliance requirements and working in tandem with DPS so that these goals are also met by them.
Train before an emergency happens so that vendors are they are
Mhm.
compliant.
Yes.
Because in the emergency, they will not be compliant. So how do we ensure that the information is provided? I know DPS is doing some trainings so that they are pre-certified. We have enough people that are certified. Not everyone is even going through the
Mhm.
certification. So these are some of the, I think, activities are necessary to ensure that we have a pool of eligible contractors to even tap into.
Yeah, I'm glad to hear that because that's something that's really important. We shouldn't just be ticking a box if you are eligible for just one type of contract, but if we can prepare during blue sky days for the potential gray skies, everybody will be able to benefit from it. Okay, our last and final questions here are going to come from Alderman Hall.
Thank you so much. You're doing a great job, first thing first. And thank you for the information that you share with us. And then we've had 2 years of great flu shot, COVID shots, partnering with New Covenant and using Sunday morning. And then throughout the this year with the senior group. So thank you. Office was on point. My first question is about young people. Young people are just different in this generation. Are you all keeping track of, as it pertains to any of the health challenges, anything from STDs to, like, are we keeping accurate count or accurate amount of data rather pertaining to the health challenges of our young people in Chicago?
Yes. We do annual health survey. We do youth behavioral risk surveys. Our maternal, infant, child, and adolescent health team works very closely with young people, especially CPS. We have a sexual health program with CPS. We have a condom for school program with CPS, 277 schools that we support. We have mental health initiative with young people. Sexually transmitted infections, mental health related issues, violence. These are some things that predominantly, that disproportionately impact young people and that we're working with them. So yes, cycle breakers is the other one.
So no, the approach of school's great. Outside of school though, and it's a built-in audience and it's needed for sure. School is social services in addition to education, no doubt about it. Outside of school, when school buildings are closed, what pathway pertaining to messaging and marketing and what resources are available if a kid doesn't go to school that might need some of the services that you just mentioned? What's the approach, number one? And then number two, where are the places that if you're a teenager and you need some assistance, whatever that you all offer, where do they go? So two-sided, the approach and the place.
Yes, approach outside of school is still limited. Places outside of school also limited. We have our work has been designed very narrowly around particular issues, because that's how funding comes.
Right.
So we always explore where is a captive audience, where can we readily engage with young people. But we do have youth serving organizations that we engage with to get information to young people, especially around mental health. We have an unspoken campaign, mostly online. We have a vaping initiative, also mostly online, because that's sort of like the way to get to young people mostly. So we are exploring TikTok now and social media as opportunities. But this summer we tried something new around vaping with a marketing team to just try and engage people at parks. So I was at Grand Park saying, I broke up with Nick. So they had a youth breakup kiosk where people can come and get information and provide information. But that's new work, and we are trying to see how we can expand there to further engage young people. We have not really, I don't think, maximized the opportunity there yet.
I want to offer as a solution in making time. However, we need to communicate. An email would be great, and I'll put my team together. I would love to partner with you going into 2025 on various ways with the resources from your department, ways to engage young people with solutions, maybe piloting a program where we set the goal, whatever the issue is that young people are facing. And we have a plethora of organizations within the ward, faith-based community in the ward, and just people who care about young people in the ward. And we would love to work with your entire department on piloting something specific using a community-based approach beyond the normal agencies in CPS. The other question that I have is what trends are you beginning to see pertaining to young people as it pertains to dangerous health trends that we need to focus on with our young people? And young to me is under 30.
Right.
So 30 and under, what are some trends that you're seeing that we need to begin to do a better job of engaging with solutions?
So suicide
Uh,
is something that we are seeing ticking up. It used to be white, middle-aged men predominantly. That is changing. We're seeing younger Black men being impacted. So that is a red flag for us in what we're seeing there. Vaping, we already talked about vaping, like traditional tobacco getting better, but vaping is just a new problem, and it also has the same health impact as tobacco and addictive even more than tobacco. So that's something that we've just started the campaign there. And then mental health. 1 out of every 7, I believe, young has anxiety or depression. So how do we engage our youth with coping skills to deal with the challenges of living in, just really challenging times? And those are the skills. We don't want to wait until they're sick and then we give them therapy. How do we equip young people with coping skills to navigate a difficult world? So these are some of the issues, I think the top 3 issues that we're seeing impacting young people, especially the change in the suicide numbers. So we've been training, community volunteers in that QPR, question, persuade, and refer. What do you do? How do you identify like someone might be suicidal, and what do you do? So we've trained about 500 people to date, and we would like more community members to be trained, at least to know, because young people don't always talk, they don't always engage with adults. So how can you know when there is a call for help and do something?
Gotcha. So I offer again, the training that you just mentioned, definitely in this next meeting away from here on the agenda is how the 6th Ward can help with reducing suicide rates for Black men. Last thing in concluding is, you have a budget, it is what it is, but we have the medical district and so many great medical institutions in the city. 79th and Cottage, my colleague who just left, there's a partnership with Chicago State, with Gift of Hope. The old Shore Bank building is now this hub for health, conversations around health, rather. Is there a strategy in place with limited restrictions in budget and grant, all of that? Is there a strategy in place to take more of those types of partnerships with the city, using anchoring universities and medical institutions to do micro type of engagements in community through partnerships? And what I mean by that is, for example, using Chicago State on 95th and King Drive, huge campus, they have a nursing program. There's a pathway of some sort, right? With anchoring the university, community, and the city. So is there a strategy of some sort that, is in place or you're considering to anchor our health institutions with the city to do a micro reach in communities?
Yes,
Okay.
and yes, yes, yes. I keep saying to people, we have so many health institutions here. We have 350
Wow.
federally qualified health centers. We have public health departments. We have hospitals here. We don't have to do this work alone, and we cannot fund it alone. So we are open to all and every idea around partnership. That is going to be the future of our work. We saw during COVID, we need this partnership to work. And now more than ever, with the resource constraints that we have, we just need to leverage the networks that we have and build those relationships. So if there are institutions that are open, we are open.
So in concluding, again, thank you, the entire dream team of how you all have engaged. The numbers are there. So again, thank you. And our next steps is a pilot of some sort to help with reducing suicide in the 6th Ward. Secondly, developing some partnerships with proximity of medical partners in the 6th Ward in the city. And then last but not least, if there's anything that we can look at with new partners to, co-labor and be good ambassadors, we'll figure it out via the 6th and the city. So again, thank you. You're doing a 5-star job, and keep up the great work, you and your team. Thank you.
Thank you. Thank you, Alderman.
If there are no further questions, Alderwoman Taylor, go ahead.
I'm sorry, I meant to ask you this earlier. With the legalization of marijuana, are you seeing cases of young people getting access to this going up? This summer, I had an incident where some young ladies bought it at a convenience store. It was hanging up, it didn't have nothing on it, they bought it. And those young ladies were high for 3 days. And so I want to, at some point, I would like to meet with you to talk about regulating that to smoke shops and not just convenience stores. But can you, are you seeing that in a trend? Can you talk about it for a second? Thank you.
Yes, we're keeping an eye on some of the numbers, our poison control numbers, and even younger than 5 getting access to some of this. We're seeing those numbers, so that's a concern that we're seeing.
Can you send us the number ward by ward about what you're seeing and then talk about what we could send out to constituents and put on our websites and send out in newsletters about safety?
All right.
Thank you. Thank you.
Yeah, and thanks for that question, Chair Taylor. That's something I think we all need to talk about in terms of just how readily available non-cannabis items are, right? THC, Delta 8 and other like hemp-derived products. And I think that's a revenue opportunity as well. But we definitely need to talk about regulation for that because they are too, they're way too available and there's no regulation around it currently. I know that's a lot that's got to be done at the state level, but that's something we should be taking up. With that, I think we're done. I'm looking around. There are no further questions, Dr. Ige. Thank you to you and your staff. The committee's going to stand at ease until 5:30 while we transition to the next group, Department of Buildings.